Welcome to our first sports medicine conference for athletic trainers. The physicians at Rebound have had a great relationship with the athletic training community for many years, and we're excited to put on this conference for you. Our relationship with the athletic training community is vital to our practice, and we would like to remain a big part of your practices in the future. The goal of the conference will be to provide a program that will focus on practical skills that you can use both on the sideline and in the training room. Our two athletic trainers at Rebound have been instrumental in developing the program, so we're really hopeful that our talks and our breakout sessions will be relevant to you and help your practices in the future. I think we have a great lineup of speakers for you today. Our first speaker, Dr. Brian Regal, is a neurosurgeon. He'll be speaking to you on the evaluation and management of pediatric back injuries. This afternoon, he'll be available for the breakout sessions. He'll go over practical aspects of the physical exam and answer your questions about diagnosis and treatment. This morning, after Dr. Regal speaks, Mike Baer, physical therapist, will be speaking on the rehabilitation of adolescents with back injuries. He will also be available this afternoon during the breakout session with Dr. Regal to answer your questions and go over exam skills and rehabilitation techniques. Our second speaker is Dr. Jesse McCarran. He's a shoulder specialist, and he'll be talking to you about the most recent updates and what's the latest in shoulder surgery for the throwing athlete. Helen McDevitt is our physical therapist and resident shoulder guru. She'll be giving a talk on latest rehabilitation techniques, both non-surgical management of shoulders and post-surgical management of shoulder injuries. Jeff Cravault is our athletic trainer who's a specialist in throwing athletes. He's managed many throwing athletes, both post-surgical and non-surgical, and has designed throwing programs for them. Jeff will be giving a talk on rehabilitation of the throwing shoulder. He'll also be available this afternoon for the breakout sessions and go over his techniques and return to play programs for throwers. Dr. Frazier is an orthopedic surgeon who has volunteered to speak for me in my absence, so I really owe him a big favor. He's going to talk to you about ACL injuries, surgery for ACL and meniscal injuries with the latest updates for those. Rob will also be available this afternoon for the breakout sessions, and he can go over some diagnostic techniques, physical exam skills, and post-surgical management. Following Dr. Frazier's talk, Steve Rossaretto, athletic trainer with years of experience in athletic injuries and a specialty in knee injuries, will be speaking on ACL rehabilitation. He'll also be available this afternoon during the breakouts, going over exam skills and rehabilitation techniques, both non-surgical management of knee injuries and post-surgical management of ACLs, meniscal repairs. You may be wondering why I'm not present at a conference that's named after me. Unfortunately, I won't be able to make it due to a previous commitment that, as usual, I wasn't aware of, but my wife of 40 years, Amy, was. So I will be in the Caribbean trying to have fun while you're at this conference. We're excited for this conference, and we really hope it'll be educational, practical, and relevant to your practices. We'd like to hold this conference annually, so we're hopeful for your feedback, both good and bad. We'd really like to know how we can make this a better conference for you, both from a practical and an educational standpoint. Please have fun and enjoy the great speakers that we have assembled for you. Thank you.
Wanted to focus on three cases that I really struggle with athletes. The first one is just the standard run-of-the-mill axial low back pain. It's very common in just the general population, but it gets a little more difficult in athletes, especially as they're trying to progress to the next level, progress through a series of exercise, perhaps through an injury, and it's just low back pain. So Moving to the second case is leg pain. So that's a pinched nerve in the back commonly, and so that's gets a little bit difficult with athletes because they're very keen on getting back to play, and we know that if you leave those patients alone in a year, if you manage them non-operatively, they're just as good as the operative group at a year. The unfortunate thing with athletes is they're oftentimes wanting to get back to play. So that is a little bit different of a paradigm shift from a surgical standpoint, because oftentimes we'll try to drag our feet as long as we can before we operate on a herniated disc. With athletes, it's a little different because they want to get back to play. Then it becomes, is it a high school athlete or professional athlete? The professional athlete oftentimes will get surgery maybe a little bit quicker because they need to get back to work. Whereas the high school athlete, it becomes a little bit more of a heart-to-heart with patient's parents about what's best for kid. And so that's a little bit different. And then finally is, what to do with a slip or a spondylolisthesis. Not uncommon congenitally. And then it's a problem for the female athlete, the bending backward athlete. So that's going to be the gymnastic, usually female. It's gymnastics as a kid. And then for men, it's usually with wrestling, but it can be from any of those. I'll kind of gloss over kind of the rehab stuff. We have good speakers on that today, and kind of focus more about my surgical decision making in the athlete in general. 3 parts of the cervical spine: cervical, thoracic, and lumbar. 7 cervical vertebral bodies, 12 thoracic, 5, sometimes 6 lumbar. Just the terms, what I found working with our physical therapists and athletic trainers is oftentimes we talk a little bit differently. So from a stenosis standpoint, it just means narrowing. And in the spine, and so this would be an axial cut through the spine, there's really 3 different places where the spine can be narrowed. Right in the middle, and that would be central stenosis. Out in the lateral recess, or the sides of the central part of the canal, which would be lateral recess, and then foraminal stenosis. And those are the 3 different spots that nerves will get pinched. And then radiculopathy, pinched nerve. And you can get it in the arm, you can get it in the leg. Very classically, if somebody has a pinched nerve in their leg, in their arm, if you just ask them to draw it, I found over the years, if you ask them to describe it, very difficult, sometimes vague. Pain can be hard in terms of, but they very consistently will always draw you a pattern. So I've honestly stopped asking them. I ask them kind of for a little bit, I'll let them fumble with the answer, and then I'll just say, can you just take your hand and draw where your pain is at? And they'll very subconsciously almost draw out a very typical pattern of what you'd expect that pinched nerve to be, whether it was in the cervical spine or the lumbar spine. But this is a collegiate pitcher, increasing low back pain for 2 years with pitching, associated with intermittent right greater than left leg L5 distribution numbness, denies any weakness, denies any changes in bowel or bladder. On exam, tenderness, and then full strength. Here's the x-rays, so AP and lateral x-rays. 5 vertebral bodies, numbered 1 through 5. And you can see that the L5-S1 level looks a little degenerative. As we age, this is a very common disc to degenerate. Every bone takes up the weight of the one before, so it's very common for this to be a degenerative disc. In the 20s, though, it's a little odd for this to be degenerative this bad. So I would say degenerative disc disease at L5-S1, more than appropriate for age. And then some of the joints in the back, the facet joints, are degenerative as well. They just don't look as clean and crisp, and so I'd say facet arthropathy. But no instability on flexion extension, and that's what I really like about the x-rays in the young patient or the athlete, is determining whether or not they're formally unstable. We'll give them a few millimeters of motion, and we'll call that physiologic, but nobody should really move more than about 3. For axial low back pain, usually we don't jump to an MRI, but when they get to me, I usually have one or I get one. What I'm looking for on the MRI is I'm looking for a pinched nerve. Sometimes a subtly L5 or S1 pinched nerve can manifest itself as back pain. Going up from there, though, decompressing that nerve doesn't always work. So I tread very lightly on that finding without it going all the way to the foot in terms of operating on people, but just knowing that a subtle pinched nerve. I'm not sure why that is in terms of why does it zing all the way to the leg. I think it's because the nerve to the facet complex, so as the nerve exits, it wings back around and gets the facet complex. I think that nerve can get irritated, either from facet degenerative changes, irritation, or it can be pinched and irritated. I'm not sure, but we tread lightly from a surgical standpoint on decompressing nerves in the setting of back pain only. So what actually hurts? Well, after talking with Mike Baer about this over the years, it turns out that I very quickly am very uneducated about the muscles and the facet complexes in the back. We get so focused as we move along in our education, and I think we forget those things that you had to study when you were going through school, and then you tend to forget those things if you're just not using them on a daily basis. I tend to focus on things I can fix, so I can fix herniated discs, I can fix instability. So I'm not as astute in terms of knowing the small muscles in the back, but I know where the nerve endings are. They're in the muscle, they're in around the facet complex, they're in around the disc space, and then they're in around the periosteum or the bone itself. And trying to figure out which one of those is actually the pain generator, I haven't found a good mechanism for. I think the best thing is feeling their back and having them point to where they hurt, because a lot of people will tell you their back hurts, and it turns out that it's their SI joint. The other thing is that if you feel their back and it feels just a little off midline, it feels like a facet complex, I think that's probably facet. In terms of kind of walking them through what hurts, what makes it hurt, what doesn't make it hurt, I think the mechanical loading, makes sense to me that that's either a disc or facet complex, whereas if it's just present all the time, I'm not sure what to make of that. Like the person that's having a heart attack, the left arm hurts. The left arm is fine. It's their heart that's the problem. And I think back pain is kind of a similar phenomena. The whole thing hurts. I can't tell you where the pain generator site is. And so that becomes very difficult for patients in terms of understanding, because they want an answer. And it becomes frustrating for us as well, because we don't necessarily have an answer. The good news is that usually back pain is very limited, and it can get better in time. For most patients, it's about 3 months, 3 to 6. For young athletes, it's a little quicker. The caveat to that is if they're trying to push their way through an injury, they can continue to kind of get in this cycle where they're re-injuring it slightly. So those people, we try to maybe pull back a little bit. But you're all keenly aware of the therapeutic modalities for the non-pharmacological or non-medical management, non-medicine management of low back pain. We have good evidence that these things really work. In the athlete, it comes a little bit more complicated because they're oftentimes anxious to get back to play. So when they get to me, they've usually been through the whole ringer. And at this point, what do I do with them? Knowing that from an operative standpoint, I don't have a great answer for them in terms of looking in the eye and say, I'm going to do this surgery on you and you're going to feel fantastic from fixing your low back pain. I can fix a herniated disc in terms of unpinching that nerve. Those patients will get better. If they have a spondylolisthesis that we'll talk about, we can fix that, but the results of that are mixed. So for just back pain only in the young person, I do two things. I'll get this CT SPECT scan. It's a CT scan which will give you really good bone anatomy, and at this point usually the first line is always an MRI. It'll miss a subtle pars fracture. So oftentimes if it's your bending athlete, the wrestler, the gymnast, the football player that's had an injury maybe before in Pop Warner even, it's very subtle that you can miss a pars fracture. So I like the CT SPECT for getting a small, subtle fracture at the facet complex of the pars, which connects the two facets together and prevents that translation. I like that to rule that out. The second thing is it's a radioactive study. I maybe don't get it for the kids as often, but what it is a radioactive phosphate group. Bone is calcium phosphate. We know that arthritis, this is a great arthritis scan. A spectroscopy scan is a great arthritis scan. So we infuse a radioactive phosphate group. It circulates in your body for a couple hours, and then we put you under a fancy Geiger counter. We take that fancy Geiger counter, which shows you these hot spots that you can see, and we marry that with the CT scan. So the SPECT aspect will give us definition of where the arthritis is or where the bone turnover is, and the CT scan will localize where that's at. And so what I'm looking for is I'm looking for it to localize to a specific facet complex or an end plate, and then at least we feel like we're a little smarter about directing care that way. The problem is when you hurt right in the middle, you can be one level up, 2 levels up, 1 level down, 2 levels down, and you really don't know. So I find this helpful in those very difficult cases. If it shows one place is hot, at least we think we're on the right track in focusing therapy there. Maybe we can get an injection for a steroid injection. Maybe we can start laying off some of the lateral bending exercises if it's lighting up like that. More, it's just making sure we're not missing anything. And then I'll run through the arthritis scan. So oftentimes ankylosing spondylitis, which is a hereditary disease or can be sporadic, it can manifest in the young patient as low back pain. So I'll get an HLA-B27 marker, which doesn't mean they have ankylosing spondylitis, but at least it's a marker for possibly later on the development. Then if it is positive, I refer them on to a rheumatologist. A rheumatologist, they change the criteria for that diagnosis, it seems like every about 5 to 10 years. But usually it's a diagnosis of, you have to have 3 of 5 things. That's usually things like sacroiliitis, another joint that is also bothersome, a shoulder, a hip, elevated markers, family history. And so the diagnosis of ankylosing spondylitis is a set of criteria that you have to send them to a rheumatologist for, and the HLA-B27 marker is the first step in that, but it doesn't mean that they have it. If they do have it, it means that they need to commit to really a lifetimes of some type of exercise that maintains stability and strength of their joints. They're gonna hurt, they're gonna have arthritis as they get older, but things like swimming, yoga, developing long, lean, stretchable muscles to support, they'll do better than if they don't. They're gonna hurt either way though. If they don't move, they'll hurt. If they move too much, they hurt. It's a tough one for them. Most of them, fortunately, improve over time. And in the case of the HLB27, I try to get them in the right direction in terms of getting to a rheumatologist. Herniated disc is almost a little bit nicer for me because at least we have something very defined that we can point to and say this is why it hurts. So 22-year-old runner, increasing leg pain after running for about greater than 5 miles. He's training for a marathon. Up to about 4 miles, he's fine. Then for some reason, just after 5, he just starts getting this pain down his leg. And then he has dorsiflexion weakness. Here's his MRI. So on the left, it's a T2 sagittal MRI. I like this particular view because it shows the cerebral spinal fluid as white. And so looking at the spine from the side, the bones in the back stack up in one of like building blocks, so L5, L4, L3, L2 with a disc in between each one. And you can see the disc between L4 and L5, the L4-5 disc, has this large herniation posteriorly, and you can actually make out the nerves as they traverse the central canal, and you can see this one draped up and over. Here's an axial cut, which shows it's a little backwards. The Germans, when they first invented MRI, envisioned the patient being sliced from the foot towards the head. So the right's always going to be opposite you on the scan. So like on this particular side, the disc is actually on the right side, which is a little counterintuitive. If you just look at the scan, you say, oh no, that's a left side, it's a right-sided disc. So herniated disc on the right, it fits what they're complaining of. We've done good studies looking at this. So it turns out if you flip a coin and you randomize patients to either a non-surgical or a surgical group, they're both happy. 90% are going to be better at a year, and they're both happy at a year. The tough it out group, they're definitely in misery for a longer period of time, and that becomes a little bit of an issue with athletes because they want to get back to play. So I tend to find myself operating on that athlete that's dependent upon maybe for their livelihood and they're truly held up. It gets a little bit more sticky if it's the high school athlete, if they're wanting to get back to play in terms of operating on them. The real issue is long-term, you have to take some of the facet complex. We know that we get away with taking about a third of the facet complex most of the time. 80% of the time we get away with taking a third of the facet complex, but 20% of the time we don't. And what that means is 10, 20, 30 years later, they start to develop a little instability at that level that may require a fusion. So that's really, I think, the big risk long-term in the young patient is going forward. It sets them up about 20% of the time for perhaps another fusion down the road. But these are all the different things that they can try. I encourage people to try them before considering surgery if they can. The reason to do surgery up front really is for incapacitating pain or patient preference. Unfortunately, nobody has to live with their pain but them, so it becomes their preference. A little bit of weakness I'll live with because that'll get better. As you know, we all have seen that weakness get better with physical therapy and time. A little bit of weakness I'll leave it, and then if it's any bowel or bladder problems, that's an emergency. Or increasing weakness and it's just they're not getting better with time, we'll jump in on that. And then any pain that lasts for longer, about 2 to 3 months, at that point it's probably time to do something different. And that something different oftentimes is surprising that they haven't tried other things first, and so they got to start with that. But that's when I start thinking that surgery is okay in these particular patients. So the way we do that surgery is we operate through a small incision in the back. We go down through the muscle, I split it with a tube, and then I look through a microscope. I have to Dremel off a portion of that facet complex to get down next to the nerve. You gently pull that nerve aside and you just take out that portion of the disc that's herniated. We used to try to take out the whole disc to prevent a disc recurrence, which is 10%. what we were doing was we were giving people a ton of back pain by scraping their disc out, and we weren't decreasing our incidence of having another piece pop out. So really we should call this surgery a fragmentectomy or a fragment removal. We shouldn't really call it a discectomy. You take out that piece of the disc, you can't really look too far because you have these cables in there that are limiting you, the nerve roots, and you can only stretch them so far. So we are limited in the window that we can look, but we do feel around, sweep around, looking for another piece that's about ready to pop out. We try to grab it at the same time. But the recurrence rate is 10%, and it's an outpatient surgery. It's a good surgery in terms of relieving their pain, but that study would suggest that if they were to tough it out, they would be the same at a year. So the nice thing about doctors and studies is that depending on if you're a surgeon or a medical physician, you'll interpret that study two different ways. So that study was done, and when they flipped the coin, the purist would say if you were randomized to the non-operative group, no matter where you were at in a year, that's where you were analyzed finally. Well, some of those patients jumped over to the surgical group. So the surgeon said, well, you really can't go head to head if 20% of your randomized non-surgical patients are jumping over to the surgical arm, and then vice versa. So if you look at that study as treated study, it turns out that the surgical group perhaps did a little better. So you can take that as you may. I kind of give both patients both views. As a surgeon, I think, if it was me, if it was my kid, I would see if I could tough it out for about 2 months, 2 to 3 months, and if it's just not getting better, I'd get my surgery. I'd get my surgery earlier if I was just hobbling around and was just miserable and really couldn't get back to work or back to play. 85 will improve in 6 weeks, and then we kind of went over what I offered discectomy for. Back pain surgeries don't often work unless there's a structural problem, which brings us to our next case, spondylolisthesis. So this is a footballer from Hermiston, Oregon, linebacker, wrestler. He's a heavyweight. As a sophomore, he developed new onset low back pain after getting folded in half. And that's oftentimes what I'll see with the footballers is that it's this folded backward tackle. It's kind of this grabbed low and then tackled high at the same time. They just get folded. Usually it's a folded backwards, not a forwards. So I think what happens is they just take those pars and they offset and break them. They're so tough, though, and their abdominal musculature is so tough, I think, in some of these patients, that they just get through it. And he only had pain for about 2 weeks. He returned to play, and he'd have kind of this intermittent low back pain with some loading, but did well until his junior year. And as soon as he started playing football again, he had a lot of back pain with attacking, and then he had some intermittent numbness in his S1 distribution with loading. Hitting the tackle sled would get him, and then any kind of contact in practice. Amazingly, he denied any leg pain. He did have some numbness and tingling, which is missed there, and then no loss of bowel and bladder, which is a big one. Loss of bowel and bladder, just send them to the emergency department. That's a neurosurgical emergency. We're looking for a big herniated disc to take out. So cauda equina, which is a muscle weakness, saddle anesthesia, and then loss of bowel and bladder. On exam, he was tender in his low lumbar spine, but no, specifically, I look for SI joint tenderness, which is just, you've seen it, it's tenderness off midline, just right about where you think that SI joint would be. And then I also test the hips. Hips can, I think, refer some pain. This is oftentimes a very gray zone. So I'll palpate their trochanters, I'll palpate their hips, and then I'll range their hips as well. And he ranged fine. But this is his X-ray, X-ray and CT scan. He did have a CT scan. So X-ray on the left is the lateral radiograph. Looking at L5S1, it shows some degenerative changes, and then he has a slip here. You can make out that it just doesn't quite line up as well in the other. The CT scan shows a little better. He's offset here. It's graded, there's 4 grades, 25%, up to 25% is a level 1, 2 is 50%, less than 50% is 2, less than 75% is a grade 3, and then more is a grade 4. So he's a grade 1, almost 2 spondylolisthesis, and then his MRI is there. So why these can happen congenital, it turns out that they can run in families. Eskimos in Alaska have a higher incidence of congenital pars defects at L5. There are some families in France. They can run in families otherwise, and then oftentimes there's a history of some kind of backward bending exercise in the young growing spine is, I think, what gets it. So gymnasts as girls or males even, and then wrestling as males, but probably going to become more confident as we have more female wrestlers as well. We just covered the Oregon State wrestlers, trainers, and we're just seeing more female athletes that are wrestling nowadays. So I suspect that there'll be a setup for this as well. If it is from a fracture, oftentimes there'll be some kind of history where a period in their time, fall out of a tree, trampoline are the big ones, less than 12, and their parent will like, yeah, you know, you did kind of hobble around for about a week. And you would think they'd hobble around more if they broke their back, but it's just a week. And then over the age of about 12, it's usually some kind of folding thing. In footballers, it's that folding tackle. And then in other athletes, I've seen motocrossers who've been in bad and they hit their butt hard and they fold forward, and I've seen it do that too. So it can go either way. It can be an extreme flexion. I've seen usually extreme extension. And then as you get older, it's degenerative. The thing that gets people in the end, though, is if it starts pinching the nerve. And so this is a nice example. Here's a pictogram of the pars on the side where it's fractured. And as that vertebral body slides forward on the other one, it starts dragging that nerve with it. And the foramina on the side are dependent upon the alignment of the spine itself. So as that vertebral body drags forward, that foramina gets smaller. So what gets a lot of people is just leg pain, which we can fix. Back pain's a little bit different. I encourage people to start with just the standard, really abdominal strengthening. So what people who can take a little weight off and get their core strong, I've seen them beat it. So who have I seen beat it over the years? Athletes who are able to do that, they have to tailor some of the things that they do, and then oftentimes they don't progress to the next level, collegiate level. And so the other ones, dock workers in Longview, I've seen 2 or 3 of them now beat it, and what they've done is basically do everything that we tell them not to do, go back to the gym and lift weights. And so if you ask them, though, what they did is they went on some crazy diet and lost some weights. And whether it's paleo, whether it's kind of a liquid diet, in a way they got to get the weight off. That's the first step. And then when they go back to the gym, they have to go back as a 30, 40-something-year-old. They can't go back as an 18-year-old. What that means is no more max lifting, no more trying to lift to failure, lifting respectfully where you're doing things to develop long, lean muscles that support the spine. And so what I say is go back, start lifting, go to physical therapy person, have them watch you and watch you move and develop a program for you. But when you do go back, cut yourself some slack and don't lift to failure anymore. Don't lift max anymore, because what crushes them is usually the squat. If it does come to surgery, the goal is really to decompress that nerve and then stabilize the spine. The decompression of the nerve works great if they have a pinched nerve, 80-90% success rate. Stabilizing the spine, unfortunately, doesn't always equate to great back pain relief, because the surgery in and of itself, putting those big old screws in, as you can see, that's going to hurt. That's going to hurt your muscles long term. Those muscles are never going to be the same after you put that big incision on them. We've tried over the years to do things a little more minimally invasive. And so I think that's helped with blood loss. I think that's helped with decreased hospital stay. I think that's helped with less pain up front. I don't think that necessarily is equated to greater, longer term results in terms of better pain control, less back pain at 6 months, a year. But the way we do it is we put some rods and screws. We drop pedicle screws through the back. It's an incision in the back. And we put the pedicle screws in through the pedicle, through the vertebral body. And then we try to lift that vertebral body that's malaligned back up into a better position, lock it down with the rods along the sides, and then a cross link. And then long term, we want to lay down some bone that's taken out from that laminectomy site and get the thing to fuse solid. What it sets people up for is it sets people up for a diminished range of motion, about 2 to 3 degrees per level in the flexibility of the lumbar spine. Turns out LFS1 fusion is really more of a shock absorber, so they don't notice much in terms of flexibility. L4-5 they would. It also sets them up for a long term of beating up that facet complex above their fusion. And so we're climbing up their spine about every 5 to 10 years, it seems like, in some patients they just beat that facet up and they start to develop instability or a lot of pain at that level too. And that's the thing that we want to avoid. So over the years, as I've lost more hair, I've operated less and less, it turns out, which is pretty consistent with surgeons as they age, I guess, is what I'm told. Used to be really aggressive with these when I first started, and now I'm a little bit more conservative. But the literature would support, as you would expect, that as surgeons we do better if we fuse the spine in terms of outcomes. So who should have a surgery? If it's nerve compression and they're just beating up on that nerve, there's really no other way around it. They've got to get their spine aligned again. Or the people that I've seen beat that a little bit or go back to the gym, lose a ton of weight, and then get their abdominal core strong. Or debilitating pain and relief by non-surgical treatment, or motor weakness. And that's kind of what I reserve it for. So this particular patient, he's still in high school. He's only a junior. I cautioned him against continued play. Especially with loading. So I just, what's your plan here, kid? Are you really going on to play college football? Because if we fuse his back, could we get him back to play? There's not a ton of athletes running around there with fused back playing football. There are some running around with fused necks, which I think is probably a little bit higher risk for at least spinal cord injury. So I'm a little less concerned about returning somebody with a fused back. I wouldn't be adverse to that. But I think that parents and the kid need to be a little realistic about, what are our goals in terms of going forward? Are our goals to get you back to play? Because if that's the case, this might not be the surgery for you. If your goal is to live life better and pain better because it's limiting you, that's reasonable. But at this point, what we're doing is just focusing on abdominal strengthening and then reserving the surgical fusion. I saw him about the beginning of the football season. So probably about 6 months ago now. I haven't seen him back, so we'll see how it goes. Any questions for me? Yes. We have till 8:40, so 5 minutes. We're right on time. Yes?
Going back to the slide that you with your patients,
we don't do that well as surgeons. What we rely upon really is to getting them into kind of formal physical therapy, and then injections, and then the very difficult one will offer them that type of biofeedback for the pain psychologist. There's a few people around town that I use. That psychology thing, for whatever reason, is like kryptonite for people. They're very reluctant to have that referral made for them. They're very reluctant to go see them. Of those that actually go, and the ones that actually go are always the workman's compensation group because they have to go, they're forced to go. And those patients universally, usually by and large, will say it's a very positive experience for them in terms of learning coping mechanisms for dealing with pain. And so they do report lesser pain scores if they're willing to do it. What I found is that patients are reluctant to go. But I do mention it, I do offer it. It's like smoking, You tell them to quit smoking and all of a sudden, or lose weight, God forbid you tell them to do either one of those two things. So, at some point you have to meet people where they're at, I guess, is maybe the better answer. Any other questions? Yeah.
When you ask your patients about whether they're experiencing bladder change,
Yeah, they'll tell you that when they wipe themselves, they're numb. Okay. Yeah, that's the kind of the most easiest way to ask. How do you feel? And so they're numb in around the saddle portion, and so that's where they notice it the most. That and sitting, and then going to the bathroom.
My name's Mike Bear. I'm a physical therapist with Rebound. I've been with Rebound for about 10 years now. And my talk this morning is on current concepts in spine rehabilitation. And what I usually like to do in these situations is just get a sense of who my audience is. So I realize you're all athletic trainers. Do we have any physical therapists? I know we have at least one. Any other? Oh, great. All right. And how many of you spend at least 50% of your treatment time treating spines? Great. 25%? Great. Okay. So also, if you have any questions at any time, don't hesitate to interrupt me while I'm doing this. So, as I mentioned, today's talk is current concepts in spine rehabilitation. No disclosures. Okay. First thing I thought is talk a little bit about spine rehab history. I've been a PT for over 25 years now, and when I started, we were trained in what amounted to a biomechanical model. And what that meant was we had a very good understanding of the theoretical ideas of how the spine moved. And that was where the emphasis was. It was very bone and joint oriented, a little less focused on the muscular aspect of it. And we focused a lot on specific segmental dysfunctions, meaning our ability to actually palpate and feel what was going on segmentally in the spine. We relied a lot on palpation. I can't tell you how many courses I went to where we're trying to feel the actual very specific movements in the spine, typically in an unloaded situation. And we assumed manual therapy, which is what this biomechanical model supported, was very specific, and that our treatments were very specific. Well, oops, hang on. The reality. Well, what we've discovered probably in the last 10 to 15 years is that this biomechanical model, this very specific model of movement, didn't really take enough into consideration the nervous system and the nervous system's impact on how we move, how we stabilize, essentially how we function. We also found that the palpation of segmental levels and determining the dysfunction at those levels was incredibly inaccurate. And that manual therapy, despite all of its emphasis in the education environment, was not very specific. So what this led to is today, and where I found that a lot of really good, intelligent people that have in the past taken a manual therapy approach have come together and really created a much more eclectic approach in terms of rehab of the spine. We've recognized the real limitations of passive interventions, which include manual therapy, manipulation, all the modalities that we're famous for. And we're using much greater utilization of movement and exercise and understanding much better the neurology, how the nervous system works in movement and exercise. Greater utilization of progressive loading, which I think is a real important thing, and something that has not been emphasized in the physical therapy world, and utilization of pain science concepts. So before I get started, I'd like a few definitions. First of all, how many of you are FMS or functional movement screen, SFMA? Okay, great. So a few definitions just that I use throughout the rest of this talk, just to be clear. Talking about directional preference, and this comes from McKenzie, and their use of repeated movements to determine the direction of motion of any joint that improves the range of motion or centralizes neurologic symptoms. So basically what it means is, by directional preference, what direction does your spine patient move that either decreases their nerve symptoms or improves their range of motion. Also, I would say decreases their pain. And then the other definition is regional interdependence, and seemingly unrelated impairments proximal or distal to the primary dysfunction that may contribute to the symptoms that your patients are having. So this is what it comes down to. Evaluate with repeated movements and with a functional movement screen, okay? Reset are your treatments that are trying to normalize motion in a way that they can progress to actual stability or stabilization. And by stabilization, I don't necessarily mean core stability and that type of thing. What it really means is building in resilience to their spine, so that they can get back to either normal ADLs, normal work, or normal sports activities. So the repeated movements, which we mentioned previously, which are typically done to determine the directional preference. And in its simplest form, it's having people doing repeated movements in deflection and extension. And it's typically done in different positions. You're usually this is done in standing, it also can be done in quadruped, and also laying down. And the goal with this is to determine that directional preference, that preference that they want to move that will either centralize their nerve symptoms or decrease their back pain or improve their motion. How it determines load tolerance, and load tolerance really is how much is their spine in their current condition willing to accept, and we do that by changing positions when we're looking at directional preference. So you'll do it, you'll have them prone, you'll have them laying on their back, you'll have them in quadruped, you'll have them in standing. So different positions where they're loading the spine in differently. And then the other thing that repeated movements help us do, because we're changing those positions, it helps us determine what is the best starting position for them to rehab. If you have somebody who's doing repeated movements in standing and their symptoms do not centralize or they don't get any better, clearly they aren't going to do any rehabilitation in standing. So you're going to move them into different positions where they're loading the spine, doing less, there's less of a load on their spine. So this is an example of the type of repeated movements, and this is sort of classic McKenzie, where you'll have them do repeated movements in standing, and again, you're looking for centralization of nerve symptoms, you're looking for decrease in their pain with repeated motion, and then you're also looking for improvements in their range of motion. We show this in a couple of different positions that again accentuates the different loading in their spine. So again, as I mentioned previously, if you're finding that someone's symptoms do not change significantly in standing, we move them into supine and evaluate in that position, just to determine again, what's their load tolerance? Where are we going to start where the rehab position and what's going to be most optimal in terms of moving them forward. This is repeated movements, like I said, in its simplest form, flexion and extension. But in the reality of it, when it's done well, you will take them in their different positions of loading and load essentially try to load the spine in 3 different planes. And then the functional movement screen. This is the second aspect of the evaluation. And again, selected functional movement assessment, SFMA, functional movement screen. There are many others that can be used, and they all effectively do the same thing. And what we're trying to do is determine regional interdependence. So again, if you're talking about somebody with back pain, the classic example that we will see is hip stiffness. And typically, when you're using a functional movement screen, in this particular situation, the thing that we're looking for is stiffness. Stiffness that is typically not painful. It may be represented as asymmetry of movement through the hips and through the pelvis. And the reason why those are important is oftentimes those things can be secondary things that impact patient's spinal condition. So again, regional interdependence, we're looking for stiffness. Fortunately, in our world, one of the things that we can break through the quickest, the easiest thing to treat is this stiffness. The kind of classic example is thoracic spine stiffness and its impact on the lumbar spine. We'll see this all the time. A lot of this is postural in nature. And what happens is people are very stiff in their thoracic spine, and to accommodate for that, you'll get an accentuated lumbar lordosis, which over time, and especially in athletes, can lead to problems with low back pain. Additionally, hip stiffness or asymmetrical hip movement, if patients lack hip extension, it just sort of silently sits there, but it creates increased lordosis in the lumbar spine. As we move on to the second aspect of the overall treatment, the reset. Reset is just all the treatments that you know to use. These are manual therapy, manipulation. These are the passive modalities that are currently popular, such as dry needling and laser. They're taping, and these are the passive things. I don't spend a huge amount of time on these because I think the research has really shown that they have benefit to facilitate motion within a treatment session, but there's very little carryover. And so the point of this style of treatment is to get your patients moving better within the clinic, within your treatment, within that period of time that you're treating them, and facilitate that sort of transition into the stabilization. And so 3 phases of rehab that I like to focus on. Phase 1 focuses on isometrics, and these are basic, what I would call abdominal wall isometrics, okay? And the reason why we start there is because what we want to do is teach people, again, proper bracing techniques. And the other thing that I don't mention here that I think that's important, it's important is to be able to emphasize this bracing techniques with good abdominal type breathing. That focus, and the reason why I think it's fundamentally important is that it allows people to teach themselves or to learn how to move in a protective manner, so that they're protecting their spine while they're doing normal activities of daily living. Phase 2 focuses, we transition to functional mobility and the importance of being able to brace adequately while you're doing functional mobility, which to me is squatting, it's lunging, it's getting in and out of bed in a way that doesn't tweak their back, okay? In phase 3, we progress into increased loading, and I think this is something in the past that physical therapists have not done well. I think that we have often sent the message to our patients that your spine is very delicate and you have to be very careful with how you load the spine, and I think that's been a mistake. I think these days we're now much more we're thinking much more, how do we progressively load these spines to build this resiliency? And then phase 4, which I'm not really going to spend a lot of time on because Steve's going to talk about this today, is return to sports and work hardening. So isometrics are just very simple, this ability to contract the abdominal wall. And you'll notice I'm not spending a lot of time focusing on isolating transverse abdominis and that type of thing, which I think in limited respect has been effective in the past, but I also think it's another example of how we sort of broke things down too far and it was not very functional. What we're seeing here is the use of very simple reflexively induced isometrics in 3 different loading positions. And I think that's one of the important things, is to look at where can we load people even in this basic level of using isometrics. Okay. And again, like I said, what I like to teach is this good abdominal breathing over the top of it, and it gives patients a much better sense of control over their condition, especially during activities of daily living. Phase 2 is functional patterns, again in 3 different types of loading. And you can see here there are many, many different patterns you can use. These are just examples of essentially a squat that we're doing in 3 different degrees of loading. This is probably where I spend most of the time, is just getting people moving. And again, if you're familiar with FMS and SFMA, there are many different ways to facilitate these patterns and give people adequate stability so they can progress. And then loading, okay? And this, again, as you know, can come in many, many different forms. And I think the kettlebell people have taught us that we can really load people up as long as it's done in a smart, progressive way, in ways that teaches them that it really is okay to lift, it's okay to bend, and that your spine is a pretty resilient structure. Okay, so eval, reset, stabilize. That's what I find is very simply is where things are at in the progressive way of spinal rehab. All right. Does anybody have any questions with regard to that? Very good. Yes?
Are you using this same approach for, let's say, all 3 case studies that were presented earlier? So is this like when they go to rehab, this is the approach you're taking with it's just back pain, if it's a disc herniation for radiography, or?
You know, I think there are, yes, effectively yes. And that's what I think what truly makes it effective, is that, and remember that when we're doing repeated movements in directional preference, that's where it all starts. And that's where you get the idea of the direction you need to go with it, okay? You know, I see what you're saying with this, and you know, the thing about directional preference and those movements, they get pretty subtle in terms of how you, the examples I showed were really just single plane movements, but they really take them into triplane movements to really determine what is the true directional preference. And that, you know, we're just getting feedback from the patient in terms of, okay, what do they need to move this in the right direction to get into that more, the more rehab world where you're building that spinal resiliency. And you had a nice question with regard to the pain science piece and things like that. That's a really interesting, and that's really is our world. I think that's one of the components I didn't really emphasize a lot here, but it certainly is a big part of it. As you all know, whether you're totally aware of it or not, that you deal with this every day in patients that catastrophize with regard to back pain. And you know, I think education and knowledge is one of the keys that you know, we have to get these, especially these young athletes, through fear avoidance and really good understanding of their pain. Like Dr. Regal mentioned, 85% of these kids will just get better spontaneously. And if they truly understand that, and I can't tell you how often I've had patients come in and they will refer to an MRI from 6 months ago that says, you know, I have a moderate bulging disc. Well, no, you don't. Okay, you don't have that anymore. You know, if you're here and you're walking around, yet it's interesting to see because of their understanding of their condition, how their pain is perpetuated, how their inability to move is perpetuated. And you know, not only is the spine incredibly resilient structure, but the human body is amazingly adaptive. And that's the thing that I think we need to see. And that's what we need to educate our patients more about. Yeah?
Follow up there, looking at that based upon observation, Stuart McGill has always said that the pelvis is the platform for the spine.
Yeah.
So looking at patients who come in with low back pain, you have to hit stiffness, but how many are not able to control their pelvis and they're in an anterior tilt stiff?
Yeah, you know, I would totally agree. You know, and I think the primary thing I am looking for in when I say stiffness, I'm also looking for stability and motor control. Okay, and that's a big piece of it. Although, you know, when you think about it, you really do hit that in the stability piece as well. I mean, when you're taking people through functional patterns and functional motion, you know, you're dealing with the spinal component of it, but you're also dealing with stability and motor control through the pelvis as well. And I would look at that. I mean, that's kind of the way I look at that as well. Right? And you know, it's interesting. We separate these things out: stiffness, strength, stability, motor control. But it's all integrated together. And I think, in many regards, one of the mistakes we make is I say something like, I'm looking for stiffness. Well, stiffness is a combination of a lot of different things, and it all interplays together. And it's one of the things that I think we, as treating clinicians, we need to do is view it a little bit more that way, a little bit more integrated approach. Great. Thank you.
So I'm Jesse McCarron. I'm one of the shoulder elbow guys at Rebound. Thank you all for coming. We're very excited about this being the first year. I do want to take a quick moment just to acknowledge the sponsors for this who allowed us to put this on. People's Injury Network Northwest, American Medical Concepts, Abbott, Medtronic, Pew Synthes. These are all corporate organizations that are in our community that we Rebound work with daily, and they are the reason that we're able to provide this CME for free. And you know, they provide our financial support for this because they recognize the value of this type of ongoing education, and I greatly appreciate the fact that they allow us to do this and give us this opportunity, and I hope you guys find it useful too, but they do deserve thanks and recognition. So I should also start by apologizing. My talk is actually a little bit mislabeled. I was originally planning on talking about surgical treatment of shoulders, but as I started putting the talk together, I realized that really from a practical standpoint, that is not very valuable for you guys. I would suspect that for most of you on a yearly basis, maybe you have a couple of patients who are undergoing shoulder surgery, but on a day-to-day, week-to-week basis, it's probably not very relevant to the patients or the athletes you're taking care of and the things you're doing. So I decided to refocus this talk a little bit and step back and hopefully provide something that's a little bit more valuable and useful to you guys on a daily and weekly basis. With that in mind, I should point out there's no disclosure slide here, but I don't have any disclosures or conflicts that are relevant to what I'm talking about here today. What I am going to talk about is a review of basic shoulder anatomy and biomechanics. I find even amongst my orthopedic colleagues who don't do shoulder and elbow stuff, oftentimes the shoulder seems kind of like a black box, and I really don't think it has to be. And I think if you sort of have just a foundational understanding of the anatomy and the biomechanics of how the shoulder works, your ability on a daily basis when you're seeing patients who come to you with shoulder symptoms or specific shoulder injuries, it'll be a lot easier for you guys to sort out what's going on and figure out where you want to go with those patients from there. So I want to talk some about the anatomy and biomechanics. And then we'll move to sort of on-field assessment. What do you do? How do you look at these patients? How do you figure out what's just happened when your patient, when your athlete comes off the field of play complaining of a problem with their shoulder? And then, of course, we will talk about surgical treatment for these injuries, and also, how do you figure out both on the day of the injury as well as after surgery when those people are ready to return to play. So anatomy. So start off with the basics. Shoulder bone structures. You have your scapula, you have your humerus, and you've got the clavicle. Those things make up the shoulder girdle. If you spin the scapula 90 degrees, so you're looking end-on at it, you're looking at this pear-shaped glenoid socket. So that's the socket of your ball and socket joint. Surrounding that glenoid socket, you have a ring of soft tissue, which is the labrum. I usually think about it as kind of analogous to the meniscus in the knee. It creates a soft tissue bumper that actually deepens the sort of the socket itself, and it also is the attachment point where the joint capsule comes in and inserts around the edges of the socket. So the labrum and the surrounding joint capsule, which you see in the lower right, create the static stabilizers for the shoulder. If you then go to the next layer, you come to the rotator cuff muscles, which are the dynamic stabilizers for the shoulder. And for your patients with symptomatic instability, it's a problem with some combination of the static stabilizers, the labrum and the joint capsule, and the dynamic stabilizers, which are the rotator cuff muscles. So those rotator cuff muscles in front, it's the subscapularis. Across the top, it's the supraspinatus, and then coming down the back, you have the infraspinatus and the teres minor. Those four muscle groups are your rotator cuff. Where they come and actually attach onto the ball of the shoulder joint, they actually blend into a confluence of tendons. So there's not a distinct transition from one into the other as you come around the shoulder, but as you move back onto the shoulder blade, they do separate into different muscle groups that have varying roles in that stability process. Over top of the rotator cuff muscles, we then have all those larger muscle groups that we immediately and easily recognize: the pectoralis anteriorly, the deltoid, which wraps anterior, lateral, and all the way around posterior aspect of the shoulder, and in back, again, deltoid again. And you can also see some of the posterior rotator cuff muscles sort of come out onto the posterior shoulder blade underneath as they come medially from the deltoid. So shoulder biomechanics. The shoulder is a very large ball sitting on a very small socket. Think of a golf ball sitting on a golf tee. And that provides the shoulder with 6 degrees of freedom. The shoulder has more range of motion than any other joint in the body. But that range of motion comes at a cost. And that cost is that there's no inherent bony stability for the shoulder. The only thing that keeps the ball on the socket is that combination of those static stabilizers and the dynamic stabilizers that we're talking about. The muscles, the larger muscles that are more superficial, we're talking about your pectoralis, your deltoid, we're talking about your latissimus on your back, all these big muscles, those are the muscles that actually affect most of the large motions that you do with your arms or that your athletes are doing on the field of play. Those provide sort of the active big motions for the arm. But the rotator cuff, deep to those superficial muscles, is what provides both that dynamic stability of the shoulder that then allows the larger muscle groups to work. And it's also the rotator cuff that provides this fixed fulcrum that allows the ball to pivot or roll on the socket instead of just getting pulled one direction or the other and essentially brought partly off the socket by the larger muscle groups. If the rotator cuff can't perform its function of dynamic centering of the humeral head, your shoulder can't create a fixed pivot point around which the ball needs to rotate to bring your arm up over your head. So this is what that looks like if you actually think about the biomechanics. So if this blue point is where the deltoid inserts on the humerus, okay? And if the deltoid muscle contracts, all it really does in isolation would be actually create a upwards vector. But that's not particularly useful for your shoulder. If that deltoid pulls unopposed on your shoulder, the only thing it does is drive the ball, the humeral head up underneath the acromion, which pinches your rotator cuff and gives you pain, okay? That's subacromial impingement. However, if you have your rotator cuffs, especially the anterior and posterior rotator cuff muscles, functioning properly, those have a medial and downwards vector, which when you add in to the deltoid, will create that fixed pivot point around which the ball will rotate. And that allows you to then create that fulcrum that allows the shoulder to then elevate. So that's how these muscles interplay with each other. So now that we sort of understand the anatomy and the biomechanics of what's going on, let's sort of look at on-field assessment and the injuries that your athletes are sustaining. So there are really three basic mechanisms of injuries that you're going to see for most of your shoulder injuries. There are the direct blows to the shoulder, like you see in the rugby player on the lower left. There are the indirect loading or rotational forces that are applied through the arm without necessarily direct contact to the shoulder itself. And then there are the sort of repetitive overuse injuries. You know, think about your pitchers, volleyball players, that sort of thing. So, mechanism of injury with dislocations and subluxations. These are either going to be anterior, which is by far the majority of these that you're going to see, or they're more posterior. The anteriors tend to be a little bit more dramatic, a little bit easier to pick up. Usually for the anterior dislocations, this is an injury that occurs by a rotational force applied to the arm when the arm is in some degree of the elevated, abducted, and externally rotated position like we're seeing on the left. It will often come with a acute pain in the front of the shoulder. It could be a full dislocation where the shoulder is very obviously dislocated as the player comes off the field, or it could just be a subluxation event where they stretch or tear some of the anterior static stabilizers, the labrum of the joint capsule, but the shoulder is not actually out of joint. And that, you know, can present simply as shoulder pain, but without an obvious dislocation at the time of injury. The posterior dislocations are actually a little bit trickier to pick up, I think, because in part because a lot of times it's not as dramatic an injury mechanism. You know, the posterior dislocations or subluxations are often just an axial load. So think your blockers in football. You have your arm out in front of you, that the hand gets struck and that drives the shoulder out the back. Those people are going to have pain along the posterior joint line. It's less likely to actually stay dislocated out the back, so you're not going to have that necessarily obvious dislocation. And it's also important to point out that even if it does, if you have one of those rare patients who is dislocated out the back, posterior dislocations can actually be really subtle and hard to pick up on physical exam. They even get missed in the emergency room, and even the x-ray findings are not necessarily as dramatic as you might expect them to be. So if someone is dislocated out the back and they've stayed dislocated, you know, their arm is going to be fixed in some internal rotation. They're not going to be able to externally rotate it, but other than that, it may be really hard to figure out on the field at the time of the injury that they're actually dislocated. So let's move on to rotator cuff, bicep, and superior labrum. These are what you usually think of as your throwing or your overhead athletes. It can be repetitive use type of stuff, like the pitcher. This obviously puts a lot of rotational strain on the labrum, and especially during the deceleration portion of the throwing maneuver. That can both stress the posterior joint capsule and posterior labrum. It also puts a tremendous amount of strain on the rotator cuff, and so you can get injuries there. The middle picture here is a great mechanism to sustain a superior labrum or a bicep anchor injury. You have this arm that is abducted, externally rotated, and then you're going to apply a huge force through this bicep, and that bicep is going to, that force is going to transmit down along the long head of the bicep right to the superior labrum, and that can cause a tear there, either a one-time traumatic event, or it can be more of a repetitive sort of repeated smaller injuries that accumulate over time, which is what you start to get a sense for in this picture in the lower right. So this picture in the lower right is an MRI of a right shoulder. The funny looking triangle to the right side of the picture is the glenoid socket. The ball in the middle is the humeral head, and in this position, that arm is in the abducted externally rotated position, and that white arrow is pointing to where you see the superior rim of the glenoid with the superior labrum directly contacting the deep surface of the rotator cuff. And so if you're making hard contact between those two surfaces time and time again, that can either cause a tear in the labrum, or it can give you an articular-sided rotator cuff tear, both of which can be problems in your overhead athletes. Other direct blow types of mechanisms. The direct blow is one that very commonly causes these AC joint separations. And it can be a hard blow to the top of the shoulder. It can be a fall onto the lateral or even the posterior aspect of the shoulder that makes the shoulder blade collapse in, and the clavicle basically dislocates up and over the top. Sometimes you have dramatic x-ray findings, sometimes you don't. It can be fairly subtle, but AC joint injuries are very painful even if they're not widely superiorly displaced. So it's worth mentioning stingers too. So stingers is this sort of generic term that's often used for when someone comes off the field with painful paresthesias, numbness that went down the arm. A lot of times that is a traction. Well, anytime someone comes off the field with those symptoms that they've had an acute stretch injury to their nerves. And that can occur at a couple of places. It can certainly occur from a lateral bending or a forced maneuver in the neck that actually stretches the nerves where they exit from the cervical foramina. But you can also get those distal paresthesias associated with a stretch injury that occurs actually at the shoulder girdle. So for example, a wide AC separation where the scapula gets driven down, that's going to lengthen that area that those nerves are trying to traverse as they come through the top part of the thoracic cavity and chest wall, and that will stretch the nerves and cause zingers. Dislocations, especially anterior dislocations of the shoulder, can cause zingers too, because the brachial plexus, as it then transitions into the axilla and goes down the arm, a lot of those nerves traverse right across the front of the glenohumeral joint, and so if the shoulder dislocates out the front, that's actually going to put direct stretch and actually impact some of those nerves that are coming across the front of the shoulder, and can give you stretch injury there as well. So how do you evaluate these people when they're coming to you with symptoms at the time of play or immediately after the time of play? So one of the most valuable things is just figuring out what the mechanism of injury is. If you really know what the position of their arm was, how they got hit when the injury occurred, that allows you to narrow it down dramatically. If you know if someone's coming to you with shoulder pain and their arm was somewhere in here when that started, well, they didn't dislocate their shoulder anteriorly. Conversely, if it's a thrower, if it's a pitcher, understanding that this has been something that has been accumulating over time, and there wasn't one specific injury, that directs you to these overuse type injuries as opposed to an acute specific one-time event. So on the sideline, you need to check, see where they're painful. You know, if they have their arm up front, they're painful in the back, you're probably looking at a posterior labral injury, whether they subluxed or dislocated. Anterior joint line pain, you know, if their pain is all lateral, that's going to be rotator cuff that you're getting at over here. Obviously, if you poke at their AC joint, and that's where they're telling you their pain is, it's probably an AC sprain or AC separation. After that, getting a sense for, you know, do they have full active motion? And a lot of people are confused as to sort of how to go through with a shoulder that has 6 degrees of freedom. What are the relevant range of motions you need to test? As someone who does exclusively shoulders, you can narrow down your range of motion for the shoulder with 3 motions. That's all you need to do. All shoulder motion in any plane, all positions, is some combination of external rotation, active elevation, and internal rotation. I've never checked abduction in the last 12 years in the office. It's not relevant because it's actually a combination of the neutral rotation and a forward flexion. You can, if you have someone come off the field and you check their external rotation, their forward flexion, internal rotation, and make them do it on both sides, you're going to immediately know if they have range of motion deficits. And it is important to check the other side because everyone's motion is different. You know, some people really don't, you know, get up past 170. Some people get up to full 180. Some people, your older athletes, may only get up to 150 or 60. And if you have someone who gets up to 150 or 60 and you're only checking one side, that could be their normal, or it could be a dramatic 20-degree loss in elevation, right? So check them together, external rotation, forward flexion, internal rotation. And then if they're not able to go through that active motion, or if there's an active range of motion deficit, a mismatch one side to the other, if they will allow you, gently, cautiously checking passive motion can help. You know, if they can't bring their arm up over their head, but you can gently bring their arm up over the head with assistance, well, maybe it's a stinger. You know, they ding the nerves and they're not getting good nerve function, or maybe it's just pain inhibition. If they can't raise their arm up over their head and you gently try and put it through range of motion and it won't go through range of motion, then it's probably a dislocated shoulder, right? So these passive active mismatches can help you. And then of course, checking neurovascular status, make sure that they've got intact symmetric sensation in the hand, forearm, up here at the shoulder, lateral deltoid. Check those things. So on-field dislocations. And we can go through a little bit more of this when we have our physical exam breakout sessions. We can talk about, you know, how to deal with these on the field of play. But the vast majority of these that you're going to see are going to be anterior dislocations. There's usually visible deformity associated with this. As I just mentioned, they're not going to have any active or passive motion. And for most people who have an anterior shoulder dislocation, the reason that shoulder is staying dislocated is because the surrounding musculature has gone into spasm and it's holding the ball out of the socket. So as you get a hint for on this x-ray of an anterior dislocation, what's really happened here is as the ball slips out of the socket, the surrounding muscles spasm and they try and pull the ball back in. But what will happen is that the posterior aspect of the humeral head will impact on the anterior rim of the glenoid and it'll get locked there. The only reason it's locked there is because those surrounding muscle groups are holding it in against there. And when those muscles eventually fatigue, a lot of times that shoulder will spontaneously relocate. So with that in mind, if you have a patient that is willing to cooperate, if there's an anterior dislocation and it's going to take 5 or 10 minutes to, you know, get them to the car, whatever sort of transportation, you know, you need to get them to the emergency room. There are a couple of gentle techniques you can try and use to see if you can get them to relocate there on the field. You know, it's at least 2 or 3 times a year that I have some poor, you know, teenager that comes to me in the office and describes how they dislocated their shoulder playing, you know, soccer, and they went to the emergency room and they sat in the emergency room for 2.5 hours with a dislocated shoulder before it gets put back in. So if you have some techniques that you can use to get them back in on the field of play, that's great. The two, you certainly don't want to do anything forceful, and if you have any concerns, you shouldn't try it. However, two really safe mechanisms. One is just a weighted pendulum. So if you get them to relax their arm, let it hang by their side, and if there's any way to apply just a steady 5 or 10 pounds of traction to their arm, and that can be you or someone who's assisting you, just gently holding their wrist and just giving us just gently holding a little pull there. If you have like something that's weighted, sometimes you can actually have them hold like gently hold in their hand a large water bottle or something like that, just even a couple of pounds. And you wait, usually those muscles, if they are trying to relax, usually those muscles will fatigue over about 5 or 10 minutes. And if you just leave it alone, sometimes it'll spontaneously reduce. The other way to do this that requires a little bit more involvement on your part, that can be a very effective method, is called the Milch maneuver. I'm not going to go into it much right now, but I'll show it to you in the physical exam breakout sessions. This does require that you actively manipulate their arm, but it is a nice, safe, non-traumatic reduction technique that can be successful without the use of any pain medication or anesthesia. I actually still use it sometimes in the emergency department because sometimes it can be successful even before they can draw medications in the emergency room. So return to play at the time of the injury. If they have full active range of motion, they have full strength, and they have no apprehension, that is to say, you can position them out here and externally rotate them, and they don't express any concerns or pain on the anterior joint line. And I think it's also important to check for posterior apprehension. So that would be having them put their arms in front and axially load to the arm. They have no apprehension and they have a normal neurologic exam. They should be safe to return to play on that day at that time. For those people who aren't going to return to play, or for those people who are having pain after the game is over, if they did return to play, obviously if you have any concerns about a dislocation or a fracture, those people need to be seen quickly. However, if you're not worried about a dislocation or a fracture, you can probably skip the trip to the emergency room or urgent care. Most of the people I see with acute injuries do end up going to the emergency room first because they're having a lot of pain, but there's rarely anything useful, frankly, other than just reassurance that comes out of that emergency room visit. So if you're worried about a dislocation, if you're worried about a fracture, if they have any persistent neurologic deficits, those people should be evaluated urgently. Otherwise, timely referral to a specialist is probably okay, and you can skip that time in the emergency room on that day. In-office evaluation. So when they come to see me a couple of days later, let them give me a history. Where do you hurt? What was the mechanism of injury? We look for provocative activities. So for example, if you check their bicep and any bicep activity causes deep shoulder pain, I'm starting to worry about a slap tear. You put them in positions like the fully elevated position. If that causes lateral deltoid pain, I'm thinking about the rotator cuff. And you obviously check for apprehension, so the abduction, externally rotated position, for anterior instability. The jerk maneuver is what we use for posterior instability, which basically means you bring the arm across the body, bend the elbow, and you apply a little force along the posterior joint line. And if that's hurting them, then you're worried about posterior labral injury. We always start with x-rays. They're usually not particularly helpful. Then we typically go to advanced imaging, which is most often an MRI for soft tissue. If you've had a dislocation, you're worried there may be a chip fracture off the glenoid, then you're talking about a CT scan to more carefully evaluate that bone. So rotator cuff. Most rotator cuff injuries that you're going to see in your athletes are simply overuse injuries, and they need to be rehabbed, but they don't need surgery. These people are not going to have rotator cuff tears. They're extremely uncommon in these younger patients under the age of about 25. So for those people, they can still do most of their things as long as they're avoiding the aggravating activities. Physical therapy is the key here. You're trying to make sure that those anterior and posterior rotator cuff muscles are really strong enough to provide that dynamic centering of the humeral head and to keep that subacromial space open. It's really important to include the periscapular muscles in this rehab process as well, because the shoulder girdle as a whole 2/3 of the motion for the shoulder after you get above 60 degrees of elevation actually comes from the shoulder blade and not actually from the ball and socket joint. So for all this activity up here, that's actually more motion from your shoulder blade than it is actually from the ball and socket joint. So you need to make sure that that's part of your strengthening and rehab process. Return to play is usually 4 to 8 weeks. It's really based on symptoms. And you want to make sure they have full range of motion, that they have symmetric strength, and they don't have any pain with sport-specific activities. Instability. So for first-time instability, for first-time dislocations, the default really should still be to assume that most people are going to be okay with non-operative treatment. Once you have your second dislocation, the chances of you having a third, fourth, fifth without surgery is very high. So that first dislocation, you want to think about non-operative treatment, but for the second, you really need to now talk with these people about surgery, because this is going to keep happening. There are certain situations where we do operate on people for first-time dislocations, and that's still, I think, an evolving concept. I don't think we're good at picking who's going to have that second dislocation after having had that first one, but we do know risk factors for that are being male, being young, under the age of 25, and participating in contact sports. This is an MRI of a left shoulder. Patients lying on their back, you're viewing them from their feet. So top part of the socket is the anterior joint capsule and labrum, and you can see the separation here between the anterior glenoid rim and the labrum. So that's where that labrum and joint capsule have peeled off the front of the socket. Okay. So superior labrum and biceps injuries. These rarely heal without surgery, but it's also really hard to establish a diagnosis. I am more concerned about a labral injury, a superior labral injury, if patients have deep-seated shoulder pain when they're trying to do bicep-specific activities. Don't rely on MRI reports for superior labrum injuries. MRI has been repeatedly shown to be terrible at diagnosing labral injuries. It both misses labral injuries that are real in the superior portion of the joint capsule, and it calls a lot of labral injuries that turn out to be false in the superior labrum. So MRI is usually done if they're failing non-operative treatment and you're thinking you're going to have to go to surgery, but I put very little stock in what the MRI is showing me. I tell everyone that it's going to be based on what it looks like when I get in there, and the MRI for me is frankly more important because it rules out other things, make sure there's not something else that I'm missing more than confirmatory for a bicep or superior labrum injury. So at the time of surgery, this is what a normal bicep origin on the superior labrum looks like. This is a right shoulder. You're viewing it from the back towards the front. You're catching a little bit of the ball of the humeral head on the right side of your screen. This is the socket on the left side of your screen, and this rolled tissue around the edge of the socket is the labrum with the bicep originating off the top. And you can see this is nice and clean. This is the bicep, long head of the bicep tendon itself as it exits the shoulder joint, shiny, smooth, that's what you want to see. This is a normal anterior inferior labrum. You're looking now at anterior joint capsule at about maybe the 4 o'clock position, anteriorly and inferiorly. So this is the area you'll tear with an anterior instability and anterior dislocation. So this was a case of a 17-year-old male. He dislocated playing basketball. He was going up for a rebound, got hit hard, dislocated. Closed reduction in the emergency room after about 2 hours. X-rays were normal. He actually was already gaining cautious, good motion even a couple of days after the dislocation. He would gently bring his arms up overhead in the office. It seemed like a very reasonable option for non-operative treatment. We put him through physical therapy. He got back to full strength, good range of motion. He was not reporting any apprehension. 10 weeks after his initial dislocation, like his second day back playing basketball, he dislocated again. So we got an MRI at this point. The MRI is right here. It shows 2 things. The first of these is this right here. That's edema in the ball of the humeral head. Remember, when that shoulder dislocates, the ball rebounds back and it hits the front of the socket. So that's a bone bruise where the posterior superior aspect of the humeral head hit the anterior glenoid rim. That is proof positive that this guy dislocated, not like there was any question about it. And then the second thing you see here is his labral injury, which is this right down here. This is This is joint capsule, that's glenoid. This is edema and a displaced capsulolabral tear off the inferior rim of the glenoid. This is what we see at the time of surgery. So for this, we rotated the patient onto their side. So they are lying down with the right side up. So think of the glenoid socket as a table underneath you. That's what you're seeing right here. Ball of the humeral head is above, and what you're not seeing in this picture is a rolled labrum, which should be running around the rim of this socket. So this is where his labrum has torn off. As we look around posterior inferior, this is the glenoid, this is his joint capsule. That's not supposed to be there. That's where the capsule is separated from that labrum. So we go in there, we drill some holes around the edges of the socket. We call them anchors, but they look like little plastic bullets. We put those in around the corners of the glenoid, and then we take the sutures from those anchors and we tie the labrum back up and reduce it back into place. So you can see these are same locations before and after. Anteriorly, and you can see we've recreated that rolled bumper along the inferior rim, and then posteriorly you can see we've gotten rid of that cleft, that divide between the glenoid and the capsule. So he just rested for 6 weeks, then he started physical therapy. He was back at full activities of daily living, but not any sports at 12 weeks. At 12 weeks, we started added weight training. He was released to sports-specific activities he was started on sports-specific activities at around 4 months, released back to high level, but not contact at 6 months, and then full unrestricted activities at 9 months. He was a little bit slower with his rehab. Most people are going back to full contact sports at 6 months, but because his inferior capsulolabral injury was more severe than most, he also developed more stiffness after surgery, which I was actually okay with. It means he healed it really well. But at 6 months, he still had a mismatch motion, active motion deficit, so I wasn't ready for him to return. It took him an extra 2 months to get that back, but he eventually did get full active range of motion and went back to full return to play. So one last case. So this is a superior labrum tear, 18-year-old soccer goalkeeper. He sustained a hard sort of fall in a dive on an outstretched arm. He sustained a type 1 AC separation. That was actually 4 years ago. That got better, but then he started having a deeper seated pain that was exacerbated by several smaller minor injuries. He had a little bit of AC joint tenderness and a little bit of scapular dyskinesis. The shoulder blade wasn't moving properly when I first saw him. His x-rays were normal, so we got him into physical therapy. Scapular dyskinesis improved, but he now had this very clear, deep-seated pain. He couldn't put his finger on it. He was like, it's down in there somewhere. And he was pointing to the superior labrum. It's incredible. Even your uneducated patients will actually, for a true superior labrum lesion, they're pretty darn good at pointing to where it is, even though they don't know what they're pointing to. He actually did not have any provocative symptoms on bicep testing specifically, but he kept just reporting this deep shoulder pain. So we got an MRI, and this was his MRI. So I told you not to trust MRIs, but this is pretty definitive for, this is the superior labrum. There's a lot of fluid coming up underneath the labrum, and there's sort of a complex tear right here. So he went to surgery. Remember, this is what normal looks like. This is what his look like. And you can not only lift it up off the socket, but in fact, if you come on top of it and sweep it down, it'll drop into the joint, which is why these people will get mechanical symptoms, because that labrum will fall into the joint, it'll get incarcerated between the two joint surfaces, and it's just like having a bucket handle tear in the meniscus. It'll be extremely painful until that labrum gets out of the joint. So normal, injury, that's what it looks like when we've repaired it. Similar to the inferior instability, rest from 6 weeks, start rotator cuff and scapular exercises for no resistance exercises for the bicep until 12 weeks. At 12 weeks, we start him on bicep activities, sport-specific strengthening at 4 months, and then full activities at 6 months. So, forgive me, I ran a little long. I hope this was useful. But you know, these shoulder injuries are common. I think if you have a good understanding of the anatomy and the biomechanics, you're going to be able to sort out what's going on with your patients, and the mechanism of injury is key here. You know, some of these patients are going to need surgery, but most of the patients who are seeing these shoulder issues aren't going to need surgery, and you just need to know how to figure out when they need a more urgent referral and when they just need some rehab and some physical therapy. I appreciate your time. Thanks for letting me talk, and thanks for coming today.
I'm Helen. I am a PT with Rebound. I have been a PT for almost 20 years, and I've been with Rebound for about 10 years. I'm going to talk about shoulders as well and continue on with from what Dr. McCarran talked about. Since Dr. McCarran went a little bit rogue on his talk, there is going to be a little bit of overlap with the biomechanics, but I think it'll be good. And the good thing is that our information is consistent, because that would be really embarrassing if it wasn't. I was like watching, I'm like, oh God, I really hope he doesn't say something that's like totally different than what I said. All right, I also have no disclosures or conflicts. So in terms of the shoulder anatomy, I'll kind of gloss over this because Dr. McCarran did a really nice job with this, but you know, this is the whole, you know, the whole shoulder joint complex. You have the glenohumeral joint, the SC joint, the AC joint, and the scapulothoracic joint. But most of what we deal with, while everything contributes to it, but the majority of what we see and probably what you all see is going to come from the glenohumeral joint with scapulothoracic issues sort of contributing, as well as some AC and SC joint issues contributing, but primarily the glenohumeral joint. Dr. McCarran talked about the golf ball and a tee analogy, and that's something that's really important, and probably the most important take home for the shoulder is just the shoulder is inherently a very unstable joint, and so the control of the glenohumeral joint by the rotator cuff muscles dynamically and by the capsule and labral complex more statically is really critical with this, because it's such an unstable joint with the 6 degrees of freedom. And then in terms of the muscular anatomy, we have the periscapular muscles over on the far side of the slide, and then the rotator cuff muscles on this side of the slide. But so the periscapular muscles are what are going to really control the scapular placement, and that will contribute to the glenohumeral joint impingements and the rotator cuff issues. And I use this model a lot, which is, we do actually have a model that's not broken. We have a few, but I really like the broken one, because otherwise I feel like people can't really see in here. And so with the rotator cuff, you know, with the glenohumeral joint, with the flat, smaller socket and the large ball, the rotator cuff muscles, some of which pass underneath the acromion here. But with the periscapular musculature, which we'll talk about some strengthening on that in a little bit, if there's tightness either in the back of the glenohumeral joint, or weakness or scapular dyskinesis, then what happens is the scapula tends to tilt forward, and then the acromion pinches down on, there's a bursa that sits underneath here. The rotator cuff muscles come under here, and the long head of the bicep come under there. And that's really important, because there's a lot of pain-generating structures that are underneath the acromion, and people, and I'm sure your athletes will talk to you about this, and they'll have heard from somebody they have a bursitis, and they'll have heard from somebody they have a tendinitis, they'll hear from someone else they have a tendinosis, and it really doesn't matter, because likely they probably have all of those things going on. So like when you go into surgery and you watch, you know, somebody who has a rotator cuff issue, generally their bursa is also very inflamed. So, you know, I don't really split hairs with that, but just seeing that all the muscles on here and how they contribute to the complex. So in terms of the shoulder, the biomechanics of the shoulder joint, you need to make sure that you have appropriate flexibility. We'll talk about the posterior capsule a little bit in a minute, which that tends to be, in terms of a static structure, the biggest issue with tightness in this shoulder, at least for overhead athletes. And there also can be some flexibility issues in the musculature. Typically the pecs and the lats are the biggest culprits there. And then when you're looking at the strength issues, the periscapular muscles, as well as the rotator cuff. And it's not just their overall strength, but it's how they fire, how their endurance is when they fire. So just a quick review, it's an inherently unstable joint. It's stabilized by both the contractile musculature, the rotator cuff, and as well as the non-contractile structures. So the glenoid, so the size, the shape, the orientation of the glenoid, the capsule and the ligamentous structures. And so a lot of times this is just something that's inherent to the person, even if they haven't had an injury. Women tend to be a little bit more flexible than men. But there are some men who also have quite a bit of flexibility in their shoulders. And one of the things that you all will find working with athletes is that people tend to be very good at overhead sports if they have a lot of shoulder flexibility, which is great for a bit. But then you need to be able to balance that flexibility out with strength. And so those people who end up getting to a higher level of high school or college performance with, whether it's volleyball or throwing or swimming, oftentimes they were able to get there because they were so flexible, but then as they age and as they do these sports for longer periods of time, things will start to catch up on them. And so they just are going to always need to be a little bit stronger than the average person because they have so much flexibility. And that's just an important thing, I think, to explain, because sometimes, they come in and they're all frustrated because they've had these shoulder problems forever, and just explain, well, the reason that you're able to get to this level is because, you have this flexibility naturally, and you just need to now accompany that with some strength. The scapular position, like I explained with the model, is controlled by the periscapular muscles, and the reason that's so important, it's not just so they stand up with good posture, but it's really so they don't get the impingement. So just keeping that away from that position, and they don't get the impingement. And then managing the imbalances of musculature and capsular extensibility, as well as pore mechanics, because if those are off, that's when we end up with shoulder injuries. Again, thankfully, Dr. McCarran and I were consistent on this with the force couples of the shoulder and the rotator cuff. It allows for depression of the humeral head, and then it brings it more into the socket. So you have that fulcrum that it's pivoting on. And that is going to allow for this increase in subacromial space. So the bursa has room, so the rotator cuff tendons have room, so the long head of the bicep has room underneath there. And the other thing which complicates this is when these contractile structures in the bursa, if they get irritated, they tend to swell. If they swell, they take up more space. So now somebody who already doesn't have a whole lot of space in there because of the orientation of the joint, now they have these structures which are larger than they should be, and so then you get into this cycle where they're irritated, so they swell. So they take up more space, so they get more irritated, and then the muscles will shut off. And then they end up with even worse mechanics. And so just making sure to explain to them that they need to break that cycle first, make sure there's enough space in there to start with, and then they can start to strengthen the muscles. And the periscapular muscles, and so those are the traps and the rhomboids, the serratus anterior, all the muscles that are around the scapula. And number one, they will pull the scapula back and down and improve and increase the subacromial space. But the other thing is that we've found that when the scapula is retracted and held back in a retracted position, then the strength that you can generate from the rotator cuff is greater in that position. So if you test somebody's rotator cuff strength when they're protracted versus retracted, they will be able to generate more power when they're retracted. So if they can be back there, then A, they'll have more power, and B, they'll have fewer injuries. So looking at the two basic types of shoulder injuries that we see and that likely you will work with, there's sort of the contractile type. I have the bursa under there, which isn't really a contractile structure, but that tends to go along with the rotator cuff and the long head of the bicep injuries. And then the labral injuries, which are the non-contractile injuries, although the bicep tendon does tend to be involved with the slap injuries. And then the more aggressive labral injuries, which are more the dislocations which Dr. McCarran talked about. The anterior and inferior aspect of the capsule are more flexible generally with people, and so people do tend to have more of the anterior inferior dislocations, but there are a lot of posterior dislocations that we do see as well. And like Dr. McCarran said, it's typically more subtle, but and there are the tests to do for it, but there are some people who come in and you can feel it sublux. You don't even have to do a jerk test. They just cross their arm and then you get that big thunk posteriorly. So for I'm going to spend a little bit of time now talking about post-op rehab, and then I'm going to go back and talk about rehab to prevent injuries, to give people just a solid foundation to work with, rehab with injuries, and then rehab more specifically with a surgery. But they're all kind of the same. It's just finding when to use the certain aspects of the rehab. So it's not like there's certain exercises that you only use post-operatively. You can use all the same types of exercises with surgical and non-surgical, but I'm just going to start a little bit with, this is a very, very general post-op rehab for non-contractile structures, and then I'll talk about a very general rehab for rotator cuff repairs. But you do need to make sure you're in touch. If you are seeing athletes that had surgery, it's really important that you speak to their physician, or you get a protocol from the physician or from a PT. You can get it from their physician, because even within Rebound, they're all different. And they, as you may or may not know, they get pretty particular with their rehab protocols. And so you do want to talk to the physician and find out exactly when are they okay with starting rotator cuff strengthening, when are they okay with stretching, how far are they okay with you stretching them. But in general, and this is really critical, with any sort of a non-contractile type surgery, so a capsular labral surgery, remember this is a stability surgery, and don't overstretch this, and don't stretch it too aggressively too early. So you can always stretch out something that's tight, but if you make it too loose, especially too loose too soon, then this person's going to be back in the same position which they were prior to their surgery, which is really bad. So and it's sometimes hard for these people, especially if they're people, it's different when they have like a, traumatic dislocation. Maybe they weren't super loose before, but for people who just are a little bit, have a lot of flexibility in their shoulder to start with, and then they end up having one of these surgeries. They're used to being loose, and they probably play a sport that requires a lot of flexibility, and they're going to feel tight, and that's going to feel uncomfortable for them, and it's going to bother them. But you just need to explain to them that that's okay. I kind of want them, when they're 6 months post-op, I would actually rather them not be 100% symmetrical with their flexibility, because they'll get there just with maturity of the tissue and the histological changes that will happen as the tissue matures over 9, 12, 18 months. Their flexibility will continue to improve. It needs to be good enough to be functional and to be able to at least start to do some sports. But if these people came in and they, on their other side, or what's normal for them maybe is 120 degrees of external rotation, I don't particularly want them at 120 degrees of external rotation that early. They'll get there. So just make sure you don't restore their flexibility too quickly. So in general, when somebody has a capsule or a capsular labral type surgery, they're in a sling for about 6 weeks. A lot of doctors will have them out of a sling sooner than this for this type of surgery. They're typically a little bit more consistent with the sling use with the rotator cuff repairs. But within that 6-week period, starting with just some sort of scapular mobility, so within the sling they can just be doing scapular retractions, scapular depressions. They'll often, a lot of the surgeons will have them do what they call a salute exercise, which is a salute, so like that. And so it just keeps them in this plane, and at least it gets their arm moving a little bit actively. And then they'll often allow them to externally rotate either actively, or they'll have them do it with a dowel to about 30 degrees by the side, but no external rotation up above yet. Typically at 6 weeks post-op, they'll get out of the sling, and we'll see them in PT somewhere between 4 and 6 weeks post-op. And that's when I noted there also just cautious range of motion. So stretch them, start to get them moving. But you can start the strengthening at that point. So scapular strengthening, light rotator cuff strengthening. Typically I'll start with rotator cuff isometrics. And then starting at week 12 that's when I'll start to push the range of motion more, and that's where I'll start. So if it was an anterior labral issue, I'll have them start the 90-90 stretching there. I'll often do some passive 90-90 stretching before, but I won't have them do like anything like in a door frame or anything before about 12 weeks, which is a little bit more aggressive. Something else that's really important for whether the person had surgery or if they're just out of play is to use these early phases to address spine issues, so stiffness, which I'll talk about in a little bit, core strength, hip flexibility issues, cardio. One thing that's important for these players to know, and often just at least gives them something to do, is that this is hopefully going to be the longest time they're not playing a sport, at least during this athletic piece of their career. So use this time to, if they're a basketball player, get really good dribbling with your left hand. If they're allowed to run, getting their cardio going, or biking if they can't run. But really to not just sit around for 6 weeks and just get really out of shape, because then they're entering the rehab phase where they can be doing a lot of things with just this really crummy base that they're starting from, and then they're weak, and that's just going to set them up for a much longer rehab process. So, and this is really important for you guys, because we often don't see them very much during that 0 to 6 weeks phase, but they're seeing you all the time probably. So just make sure they're not just like sitting around playing video games and getting fat, that they actually need to be working and having if you can give them a really structured program, that will help them so much just long term. So with a rotator cuff repair, which again, you don't see very much, I've seen, I think like 2 ever high school kids have rotator cuff repairs, but it happens sometimes. But the rotator cuff is a contractile structure, and this is kind of the opposite of rehab. So we typically don't see them until they're 6 weeks post-op, occasionally a little earlier if there's somebody that the physician is concerned about their flexibility because they've had a history of adhesive capsulitis or something like that. But do range of motion before strength. So I'm pretty aggressive with a range of motion here. Early passive range of motion, which we're doing hands-on with them, and they're doing at home. You don't really start, you can start a little bit of scapular strengthening at about 6 weeks post-op, but you really don't start, any rotator cuff strengthening until they're 12 weeks post-op, and make sure, and we'll talk about that in a minute, that you really progress from very, very light below shoulder height rotator cuff strengthening first before you start to do anything up overhead. And it's just very important to allow for the rotator cuff to heal prior to strengthening, because these things definitely do re-tear. So this is just what I went over. Oh, and again, just using those early phases of rehab again to address the other issues that aren't the shoulder. So shoulder range of motion. The biggest issue that we find, and this is typically for non-surgical people, but it sometimes leads to them having to have like a labral or a capsular surgery, especially for throwers. We see this a lot in baseball players, also in swimmers, is glenohumeral internal rotation deficit, or GERD, which is internal rotation deficiency up here. So the one thing that they've found, so it used to be when we first started talking about this probably 10 or 15 years ago, that it was just all about internal rotation and you comparing the right or this dominant side or the throwing side versus a non-throwing side. and making sure that they're within about 15 degrees of one another. But what we found is that sometimes, especially people who started throwing at a very young age, will get some torsion in their bone, and so they'll just be lacking internal rotation just from a bony standpoint. And so you want to look at their total arc of motion. So you do still want, you want both shoulders to be within about 15 to 20 degrees in terms of symmetry with their range of motion. But if on one side they have 130 degrees of external rotation and 60 degrees of internal rotation, then what was that, 190? So they have 190 total on the one side. If they have about 180, 190 on the other side, that's kind of okay. But it's the people who have 110 degrees of external rotation, but then like 20 degrees of internal rotation compared to something that's very different on the other side. So do make sure that you are comparing both the total arc of motion, both the external and the internal rotation. And it's important that you check this and you stretch this with their scapula blocked. So most of you have probably seen and done and had your athletes do the sleeper stretch, which is this guy right here. And the reason that he's lying on his side is because it blocks the lateral edge of the scapula. If you just have somebody stretching into internal rotation like this, oftentimes what they'll do is they'll just be stretching their whole scapular area, so you're really not getting a lot of stretch at the posterior part of the capsule. So if they lie on their side, and you'll see a big difference. If you look at their internal rotation when they're even just lying on their back, they'll often look okay. And then if you have them onto their side, you'll notice that it's really tight once their scapula is blocked. So this is a good, I think this is probably the most effective stretch for people to do on their own, is the sleeper stretch here on their side. There he's doing it upright, which also works, but it's a little bit more practical, so they can do it just like when they're at the field, just standing, and he's blocking the side of his scapula just on that post. I think the sideline one's a little bit more effective, but they both work. Something else to address the posterior capsule. The research for this is pretty gray, but anecdotally, I think it seems to work for my patients at least a couple times, is any sort of A-stim or Graston to the posterior capsule, so scraping. That's if somebody's really, really tight back there. And so just doing a little bit of the scraping first and then have them do the sleeper stretch. I don't go too crazy with it, but I'll often do it a few times, especially if they come in and they're really, really tight. I mean, some people come in and they have like 10 degrees of internal rotation, and it's amazing they were able to throw at all without pain. Other areas of tightness to look at in the shoulder are just their chest and their pec tightness, and then their lat tightness. I'm not a huge fan of the doorway stretch for the pecs or for external rotation, unless it's somebody who had surgery who just really needs some cueing to keep their arm up there. But I don't really like when you are pressing all the way in forward, because it tends to really aggravate people's bicep tendon, which is a really big pain generator for the shoulder. So I prefer attach the microphone, like a wall slide here, and then just having them actively retract their scapulas, bring their arms back, and then trying to keep their elbows and their hands on the wall. I think that is a little bit more effective, and it's less irritable on the long head of the bicep. So the spine, and Mike touched on this a little bit when he was talking about the hips and the hip tightness in the lumbar spine, but the same thing happens with the thoracic spine and the shoulder. Is if somebody is really tight in their thoracic spine, then that's going to increase the demand on the shoulder. So if they really have very limited thoracic spine extension, then they have to, if they're going to throw or do anything up here, then they're going to need more external rotation in the shoulder, which then tends to set people up for more anterior labrum and bicep tendon issues. So, and this is again something that somebody can do if they've just had surgery, or if they're not, if they're really not able to do a lot of shoulder exercises. They can keep the one hand here. An extension stretch over a foam roll works really well. Also, thoracic rotation and lumbar rotation. First of all, will also, if you're really tight, it's going to increase the demand on the other parts of your body, but you also are going to be able to generate a lot less force. And so just from a performance standpoint, it's really important to make sure that your players are maintaining good rotation in their spine so they can use their whole body to be throwing and they're not just throwing with their arm. Range of motion of the hips is also critical for the shoulder. This is something that's been coming up a lot more lately with shoulder and elbow injuries, for UCL injuries and other types of shoulder injuries for throwers, is that we've found that throughout a season, a baseball season, players will start, especially pitchers, start losing external rotation in their hip as the season goes. It just starts to get tighter and tighter. And as you lose the rotation in your hip, then that increases the demand on your lumbar spine. It increases the demand on your glenohumeral external rotation and also the elbow valgus force. So, and then also, which players seem to care about more, their performance, it will decrease their power as well. So just making sure that the players have good hip flexibility, so hip extension, hip rotation primarily. Because those are the ones that tend to get lost. And then your core, so your legs, your glutes, your periscapular muscles, and the rotator cuff. So with strengthening, obviously, core is a big thing now. And this is something that can be done, again, very, very early on in the rehab. And you couldn't be doing, the top plank one early on if you had a shoulder surgery, but you can be doing bridges, you can be doing side stepping. We'll show you pictures of those in a second. But there's all sorts of core exercises which can be done and which should be done, because the stronger you are in your core, again, the better, you're going to be able to perform better, but you're also going to be much less vulnerable for other injuries. Jeff's going to come up and start to demonstrate some things. So I didn't bring a med ball over, but so these are just a couple just core strengthening exercises which we use just outside of just the typical planks, bridges, side stepping, and things like that. So with a medicine ball, if you just get your throwers to more go through the throwing motion and just stepping up onto things. And so if somebody just had surgery, they're not going to be able to hold, he's holding a little ball, but in the picture he's holding the medicine ball. They're not going to be able to hold a big one, but even just starting with just throwing and hitting motions. And then, when you're doing the core strengthening, you want to make sure that you're not just working in the sagittal plane and that you're doing things in the transverse and in the coronal plane just to work all different aspects of your core. Another core muscle, or really scapular muscle, I guess, that I think is often forgotten about but very important is your serratus anterior. This is a great exercise. We show that really quick. That's like that. I know you're in fancy clothes. All right, well, like in a plank, reach over, and so making sure that you're stabilizing. You can stand up and look at Jeff. But these are also great exercises. So more of the basic scapular exercises, which you can start much earlier on. I always start low because people tend to have poor mechanics when they're first starting. So making sure you're not doing anything at or above shoulder height because they end up impinging. So middle and lower trap exercises with the TheraBand, and these are things that they can do in the training room with you or out of the field. I's, T's, and Y's on a ball or on the floor. Notice the weight. So I noticed that athletes come in and they tend to be using really, really big weights, which either they're not, their mechanics look terrible when they're using them, or they're just sort of recruiting all these other huge muscles and not the muscles that really control the shoulder positioning. Once they can start with the rotator cuff muscles, so you saw in Dr. McCarron's pictures, the rotator cuff muscles, the muscle bellies are tiny. So even under the best of circumstances with high-level pitchers, throwers, overhead athletes, you'll notice that people who are throwers at a very high level, they don't have huge arms. And so these are very small muscles. I'll see people doing like sideline external rotation with like a 10-pound weight. You really can't use your rotator cuff if you're using a 10-pound weight on your side. You're using like everything else and not anything that's helping the mechanics of your shoulder. So making sure that you're starting with very, very light bands. He has a green band. I usually start with yellow or red, and I often will max out at the red. And if they're doing it correctly, it will really, really fatigue quickly after about 12 or 15 repetitions with really light bands. Notice that he has a towel roll here. If you put a little bit of something just to give you some space under there, that just allows for a little bit more space under in the subacromial area. And so I encourage you, to have a towel roll or some sort of pad under here when they're doing it, and then also making sure that you stay in a really neutral range. So I'll have them start at neutral and go out to like 45. So don't have them go through this huge range, because again, as they externally rotate way out here, they end up exposing the long head of the bicep, and then that ends up getting really irritated. And they'll find that they'll fatigue more too if they're in this small, close-in range. So both upright and side-lying external rotation are super basic, but I think are probably the most important exercises to start with for any rotator cuff strengthening. Once they have a good base, then moving to more of like the 90-90 external rotation and internal rotation. If they have an elbow issue, then coming up there and doing the wrist exercises up in that position. Jeff will demonstrate this one. And then you start to get a little bit more complicated once, and so at this point, hopefully their core is nice and strong, and you're pulling their glutes into it, their shoulders into it. And then if they are throwers, getting them with a ball in their hand. This room it's not tall enough for Jeff, but for most people. So starting throwing here before you start doing other throwing, longer distances, ball drops. And then, especially for pitchers, just moving on to their pitching positions. I'm not going to spend too much time on this because Jeff's going to talk a lot about all this stuff, but just starting to do more sport-specific activities. But this is all after you've established they have good rotator cuff strength, they have good scapular strength, their spine is flexible, their hips are flexible, their glutes are strong. So in summary, number one, I think most important thing for these issues, because it's something that you can't ever go back on, is don't overstretch the non-contractile surgeries. Don't stretch them too early. Number two, rotator cuff muscles are very small, but they're critical. So don't try to strengthen the rotator cuff with really big weights, because it's not going to work. Wait on weight bearing at anything above shoulder height until they have really good scapular control and good rotator cuff strength down low. Use off time and early rehab time to get the athlete ready for return to sport. They will do much better, much more quickly once they get to that point, and they'll end up with much fewer problems. And just that shoulder health is not just about the shoulder, just make sure you're addressing their core, their hips, and everything else. Any questions? Yeah.
When you're doing the rotator cuff exercises, you notice you're doing that small range, more fatigue. Do you see that's more effective than doing the gross motion?
I do think I think it's more effective, and they're able to do it, especially for people who have tendonitis and things like that, or post-op, they're able to do it without pain. You do at some point need to move to larger ranges just because they're more functional, but I would, at the early stages, yes, I think it's much more effective, and it's actually more tiring because you can't use the momentum of those first, 90 degrees within here. So yeah.
Okay, because I've noticed like you go off patients that will do it and they don't control back and something.
Exactly, yeah.
I guess you're right, core mechanics, something like that, and since they are smaller vessels, it seems like that would be more of a strength.
It's definitely much more fatiguing, yeah. If you try it both ways, it's way harder to do it in the small range. Any other questions? Thanks, Jeff.
Thanks for having me. My name is Jeff Crayveld. I'm a athletic trainer with Rebound Physical Therapy. I've also been with this group for about 10 years now, and I spend most of my time in the PT setting. I also cover a high school, but it's a small percentage of what I do throughout the week. So I get to work with majority of the throwers that come through Rebound, which is what I'm passionate about and love to do. And we have a great location. I'm at the Pacific Crest location. We have four PT clinics, and at our location we have about 8,000 square feet turf and this big space to throw. So It's kind of where I love to live. I have no conflicts or interests. So what I wanted to do is, as a fellow ATC, I understand that you guys have hundreds of athletes under your care. So you don't always get the opportunity that I do to follow these athletes through their full rehab of the injury setting, post-surgical setting, and into like the return to throw and the return to sport. So I want to be able to give you guys a kind of an idea how we transition these athletes back to return to play. And put up here a few of the things that we talk to the parents and the athletes and really the coaches about. And all this data is out there for everybody. We just haven't, it seems that we're not really using the data that's available to us, because we have kids that are throwing year round, even though all of the study research is that this is going to lead to higher risk of injury and potentially surgeries. So number one risk factor in our youth elbow injuries are playing that single sport, that specialization. UCLA did a really nice study a few years back that talked about sports specialization, and even your elite professional athletes, they didn't specialize in one sport until they were around the 16 to 17-year-old age. So getting our kids, these young 8, 9, 10-year-olds starting and playing baseball year round doesn't make a lot of sense, but it's what we keep doing, our parents keep doing, our coaches keep doing to these kids, and this is why we're seeing this higher number of youth elbow and shoulder injuries in the clinic setting. Pitchers who competed 8 months were 5 times the likely to suffer an injury. That's we encourage to take the 4 months off, 2 to 3 sometimes is more reasonable for people, but in the Northwest, we have a built-in rest and recovery in the wintertime, right? Like baseball isn't played in the winter, but we see places like Portland Baseball Club up in Vancouver, we have Northwest Futures, they have these massive indoor facilities. So these kids are playing year round. Well, what we're trying to do is encourage and educate to play a different sport, to do something, let the body move in a different way in a pattern for a period of time. Other highlighted ones, pitchers, specifically over 100 innings in a calendar year, they're 3.5 times more likely. About, I would say 5 to 10 years ago, we were saying 10 times your age, and that was the max innings. So if you're a 14-year-old, 140 innings was the max. Now with the more data coming through, 100 is the one that we're going to now. So you can see a huge change even over the last 5, 10 years. And then there's the 2 to 3 month mark for the rest. A couple other studies that have been published out there. Consecutive day pitching, greater risk. The pitcher-catcher combo is a big one. When these little kids come into our clinic with their parents, we're telling them choose one or the other. The combination doesn't work. It's the two positions in baseball that throw the ball the most. So we try to get them in an early age and say, you're going to be a pitcher, you want to be a catcher. Don't do them both. Multiple teams, again, with all the showcases, all the club sports, like they're going year round. Anybody, if you collect all the data on these injured athletes, a lot of them play multiple teams and multiple teams at the same time. So you have coaches that don't talk to each other, don't communicate. They're just trying to win baseball games, and these kids are thinking they're going to get recruited. Curveballs and sliders also. It's been a up and down kind of. I went to an ASMI course 10 years ago that said actually no, throwing curveballs isn't bad, but now it's been bouncing back and forth. I think it all has to do with the repetition, right? Just how frequently and how often they're throwing. That's what really it comes down to. So Helen did a great job of just recapping from the rehab side of things. So I'm just going to kind of just briefly go through with my throwers what I'm looking at when Dr. McCarron sends them to us, and we do our initial evaluation, and what over the next time frame, 6-12 weeks, that I'm going to be treating them, what things we're going to stay on top of. So range of motion, talked about the total arc. Elbow extension, we got to remember that, especially with our post-ops, right? You got to make sure we're getting full, because you'll have a kid come in with an elbow injury, and you look at both sides, one's lacking 10-15 degrees. So we got to work on maintaining that normal passive and active range of motion through the elbow as well as the shoulder, as we know. Strength, we kind of hit on a few of the things we do in the clinic, upper and lower extremity. I add a lot of glute work into that, so while I'm doing all that band stuff, they're also got bands, you know, the lateral resistors around their ankles. They're doing a lot of the combined movements with a medicine ball. We're not just doing one plane, we're changing the planes. The step up to twist you saw, we're working on that rotation, generating force off the push-off leg, and then rotating through the left hip, which is their plant leg for pitchers when they land, and for throwers. When they land, they're rotating through the left side. So we're just trying to build that strength and keep those muscles moving. It's a use it or lose it. If you don't use those muscles, they're just gonna sit there and not be effective for the thrower. So again, if we have a patient comes in, an athlete, a thrower, pitcher, we're gonna shut them down for 6 weeks, okay? So they've had the injury, they've had an MRI, they've had an X-ray, 6 weeks of no throwing, and this is just kind of our standard, what we go by. Sometimes I'll fudge on that a little bit, just depending if I get a good history of the kid. If he's a 3-sport guy and he did play football, basketball, I might be a little lenient on that, but that's kind of our general thing. Is 6 weeks of no throwing, we're building up our core strength, cuff, glutes, hips, everything, and then we'll do a 6-week progression, throwing progression after that. And now I'll go through more of some examples of throwing progressions here later on. For me, the throwing mechanics is the number one thing. We can do all this work with these kids and these athletes in the clinic, in the rehab setting, and work hard and have them work hard on their home exercise programs. But if we don't address the mechanics, they're gonna get back right to where they were back at the doctor's office. Because you can videotape these kids and see things on the video that says, well, no wonder his elbow hurts. He's dropping down on the side, he's doing a milking maneuver to his UCL, the stress test we do to test the UCL, and that's where his pain is. So he's dropping his arm slot, he's upright in his throwing position, and I say, if we don't fix that, we're gonna be right back to where we were. So it's a simple, most of the apps out there are free that you can use. I was a big fan of Huddle. It has a great platform to where you can videotape the kid and send him through his app a voiceover recording of, hey, this is what you need to work on. Here's the mechanics. You can draw lines and use it. It's a great effective way to get the communication back and forth to your athletes. It's just an iPhone or an iPad that you use. You don't have to spend thousands of dollars on the fancy equipment when you're just doing kind of quick throwing assessment, like throwing mechanic analysis. So some considerations when we are doing return to throwing. Towel drills, Helen had a slide of it, I don't know if you caught it, but essentially all it is a wiffle ball in a pillowcase, and I have it just wrapped up. And even back in college, when pitchers, when we were on the off, so the hitters and infielders, outfielders were taking fielding, we were just sitting around twiddling our thumbs. Coaches eventually started saying, well, we can work on mechanics while stressing the arm by using a towel. So we'd go through hundreds and thousands of repetitions, and it was a great way to kind of train these mechanics. So this can be done early on, especially your post-ops. It's not a stress at all. That's the phenomenon of baseball is you have a 5.4 ounce ball that you put in the kid's hand or an athlete's hand, and now there's this repetitive trauma and stress that happens. The towel isn't going to hurt them at all. Proper warm-ups. Again, being in the Northwest, it's a little hard to get out and have our athletes properly warm up, get the blood flow going, get the muscles, turn the muscles on. I make sure that I try to emphasize running, getting the heart going. We have a lot of, as you guys all know, there's a lot of dynamic lower extremity warm-ups out there in your soccer, your basketball, volleyball, but you don't see a lot of upper body. I'll give you an example of the one that I've used before. Just again to turn those muscles on, turn our stabilizers on, ask them to work for us when we're actually doing this stressful throwing motion. Bands, of course, again, scapular recruitment, cuff recruitment, and then some of the plyo ball drills you saw. I will have guys do that pre-throwing. So that will be a part of their pre-throwing routine. And these are minimum reps. They're not like doing 100 of them. It's like 10 in each position, just to kind of, again, turn things on. Warm-up throws, again, especially at a young age, you have a coach who just tells the kids to line up on the line, they all just start playing catch and the balls are going everywhere, all over, and they do 15, 20 minutes. I want it to be a very purposeful warm-up. You want to have them count their reps. You do 10 throws, 30 feet, 45, 60, 90, and 120. 120 is the furthest we have our athletes throw. And the research backs it up. There's been a ton of analysis done at the ASMI with Dr. Fleissig, who took these athletes out on the field, and once they got past 120 feet, all the mechanics, they failed. They started dropping the backside. They had to try to get the ball higher, dropping the elbow down, trunk angle collapses, lose all that stability that they have in their lower half and all the way up into their upper body. So 120 is where you go, is the maximum we throw. And then throwing on a straight line kind of goes along with this. We don't want them to put anything under the ball. You're not wanting them to like loop the ball up because they're then changing in mechanics. I want them to try to throw it and hit their partner in the chest, and if it bounces 10 times, it doesn't matter. That's the purpose behind it, is they're trying to throw that ball in a straight line. Other considerations. We have to treat these pitchers, especially when you get to the collegiate level, you got to treat them by position. You don't want your closer in the beginning of a game, especially cold weather, going out, warming up, doing a ton of throws, getting the blood pumping, and then go sit down for 2 hours. And then coach calls the middle reliever, maybe he's been sitting in the outfield, maybe he's still been sitting on the bench, and say, hey, go warm up in the bullpen and throw 20 throws. That's not appropriate. You're just going to ask them for more injuries. So you want to treat these guys by their position. The starters should do the proper warm up at the beginning of the game, into the bullpen, and then onto the mound to start the game. Those middle relievers and closers is hard in the high school and youth level just because you don't have the number of kids. You don't have POs, what we call them, pitchers only, like you do in college. But I've seen in the high school level over the last 5-10 years that POs are becoming a bigger thing in high school. We've got, on our team, we've got 7 POs. They don't even play a position. They're pitcher only. So our coaches are treating them that way, and that's how we're keeping those guys healthy. Pitch count, we've done a great job at the youth level. Obviously, all the regulations out there, coaches can't get past this these days. And even in the high school, 10 years, well, even 5 years ago, there was no pitch count. But now in the last few years, we do have pitch count now in the high school, which is awesome. Days of rest in between, I'll show you a good resource for this stuff for all your aged athletes. Loss of IR, so also studies have shown over a calendar year or a season, but even one outing, athletes, these pitchers specifically, can lose up to 7 to 10 degrees of internal rotation after a one outing. It's usually going to be an 80 pitch or more, but you're talking about 7 to 10 degrees. That's a significant amount of loss in internal rotation. So the importance of arm care and keeping that range of motion, keeping them on their sleeper stretches, keeping on their post cap, doing the ball work in the back, the self-trigger stuff, all that great stuff you guys do in the training rooms. They got to keep it before and after they throw. And it's got to be daily. It's got to be a part of them taking care of their arms. Again, I hit on the no pitcher-catcher, and then don't throw with arm soreness. So most of the coaches will say, it's just a part of the sport. And I understand that. Playing baseball, I remember my arm being sore. The problem is that I don't think especially the younger coaches and even the high school coaches, don't understand exactly what soreness is. If it's a bicep soreness, that it's mid-belly, I'm okay with that. The biceps job, as we saw in all the presentations, how it inserts up and it's involved with the labrum. Its job is to literally pull the humerus back so it's not dislocating every time you do this massive movement. So soreness in the muscle belly, okay, but soreness like in the shoulder and elbow, we can't just say, just throw through it, get warmed up, see how it goes. We have to kind of really monitor what is pain and what's soreness. And then cool downs, kind of already hit back on that. Want them to do this stuff at the end of the game and at the end of their outings as well, just to kind of stay on top of joint health. So this was an example of upper extremity dynamic warm-up. I can't really go through all these for you, but I can show you a few of them. It takes about, if you do it at 10 reps each, I think I've timed it about like 7-8 minutes, so it doesn't take a long time. But going from the front here to 90-90 ERs to butterflies to goalposts, genies is another version of a post-cap stretch, like a sleeper stretch. Then you interlock and push, so you're pulling here, you're doing rotational side to side, forwards, back. The whole time I'm pulling my fingers apart. And then you do the opposite where you're pushing, maintaining the push, rotating, elevating, back and forth. That's interlock push, interlock pull. The 90-90 box, you have a thumb up, you make a box out in front, you're pushing down into it, hold, then you're pushing up, and then you're changing positions. Here, down, up, from the top to the bottom. It goes through a sequence there. Palm press prayer, similar. Finger press, you're going from each finger. I'm doing thumbs, pointers, middles, through, pinky. And then I add rotations to it, side to side movement. Same thing with the elbow side, and then press up in the prayers and rear presses. So you're pressing here, there. Sorry about this cold, it's my kid's fault. So here's into the throwing program. So this is our throwing progression. The first one up here is an off season. So we want these kids to have this adequate rest, right? This time frame in the winter. But we don't want them showing up for first, tryout, first, spring ball practice, and now they haven't done anything. They haven't done anything to, condition the arm. So this is just a nice kind of basic, doesn't even, you're 10 throws at 30 feet and 10 throws at 45. It's nothing. But it's just a nice, easy, slow progression, and because it's so simple, it can be done daily. And this is like our 4-week program that we'll give our throwers. This is one that's more geared for our post-ops, okay? This is, here's the week, so this is the 6-week progression, and then here's the days. So you see at the beginning you have a day off, so you're throwing a Monday, Tuesday is rest day, or you're doing rehab day, and then day 3, you're throwing 10 more throws than the previous, and then you get to like a weekend, so the Friday, and then you have 2 days off. So you get 2 days off on the weekend. And then it just kind of progressed down. Once we get through 6 weeks, we stop at 120, remember that, and then we go through a 6 week, so for our pitchers, it's a 6-week like flat ground bullpen. So starting out all fastballs, and it's all based on intensity. So we're doing, 20 throws in that bullpen for the first time, 50 to 70%. I've always been kind of anti-radar gun with baseball athletes, because I think what they're trying to do is just get the 90, right? Everybody wants to get recruited. They're going to make the big money. You got to hit the number. Kids always talk about velo. So I was always like, no, don't use radar guns. But the one thing I could say about radar gun is if you use it in the fashion of where you're trying to say, hey, I want you to throw at 70%. Because most of the kids, if you tell them that, they're going to throw 90 to 100. 70 to them, they don't understand that. So if you have a radar gun to use, because most of them will be able to tell you, yeah, I topped off at 89, 87, then you can actually use that to say, okay, this is where I need to throw. This is the exertion I need to put through my throw. And then, all the way to bullpen. Some of the newer devices out there that can help us in the rehab setting, but also in your guys' setting. If anybody's familiar with the Moda sleeve, this is Moda's Throw app. They've developed a sleeve that you can put an accelerometer in, and this is specific to the elbow, and it can measure shoulder external rotation, maximum shoulder. It can measure the rotational speed, so like RPMs, and then arm slot. So from where in that slot they are. And they published their information, so it's not just guys just trying to sell another thing on the market. They did find that the three metrics combined, arm slot, arm speed, and arm rotation, have a significant relationship with the varus torque of the elbow. I know that kind of threw me off at first because we always talk about valgus stress. Well, it's the valgus stress, but it's the varus torque that's trying to pull back. Does that kind of make sense? You have 1 Newton meter increase in elbow varus torque was associated with 13 degrees drop in an arm slot. So if they're a 3/4 pitcher and they drop 13 degrees, that's how much increase in stress they had. And then with the 116 degrees of rotational arm speed, so we know that the faster the arm is going, the more stress the arm. It's kind of that, what Helen was saying. I mean, yeah, you need to be able to have speed and lots of external rotation to throw in mid-90s, but it's also going to increase the stress. That's just what happens with a throwing shoulder. And then the 8 degrees increase in arm rotation. So this is what it looks like. So I set this up on this like 11-year-old, and you can see I had him just kind of drop to a sidearm position. And this gives you like the live data, like every throw. Here's his arm slot. Here's the arm speed, the RPMs, and how much maximal external rotation he has. And then off that, it gives you kind of an arm stress number based on that research that they did, all the data they gathered. So on the far side, you saw him drop it, and you can see arm slot went down to 15, and it throws a little red flag up at you saying too low. The great thing about this app is it's free, but the coaches can use it. So a coach can have all his throwers, athletes, on his app and monitor how many throws the guys are doing. So in the pros, these guys are wearing these every single time they throw. And the feedback I've heard from the pro guys is it's kind of sweaty. It's only downfall. It gets pretty gnarly there, but it will pull out a calendar of the month, and it will show you how many stressful throws on what day you did. So it can kind of generate a throwing plan for them. Like, okay, on Tuesday I had 12 out of my 50 throws were stressful. So it kind of gathers, it kind of keeps that input, and then as you go throughout the day, it will say, okay, on Saturday, what should I do? Well, it'll give a recommendation of the intensity that you should have, and then if you have too many stress throws, it will kind of help monitor that. So it's been a really cool app, and it is somewhat affordable. I think the chip itself is $150, and you can also use that same chip for hitting. So it's kind of fun. They can get a bunch of data on their hitting. This is a great resource that we use for the families, the parents, athletes. Our coaches probably need to do a little bit more job of looking at this stuff, but this is pitchsmart.org, pitchsmart.org, and it's a very easy website to navigate. This is Dr. Andrews and ASMI guys who really developed this early on with the Little League stuff, and they've moved into it. But you can go in and click on the guidelines. It lists a lot of those ones I mentioned on my first slide, so you can share that data with your athletes and your coaches. Risk factors, similar thing. And then it will give you, here's the days of resting I was referencing. So you can look all the way up to age 7 to 8, all the way down to your 22, your collegiate athletes. This is the maximum pitches that they should pitch in a game, and then it says if they were at 1 to 20 down here, or 30 in our older ones, they don't need a day of rest. But as you move up that scale, the more numbers they throw, the more required days of rest. And this isn't just numbers they came up with. This is the great thing about it, is it's all based on research. And that's it. Thank you.
I've been asked to talk about ACL and meniscus injuries. So we're going to kind of go through mainly ACLs and maybe a little bit at the end kind of about isolated meniscus injuries and a little bit of what we do with them from an orthopedic standpoint. Just briefly, I got no financial disclosures to give you guys. A quick biography of myself. I kind of lived a handful of places throughout the west, middle of the country, and then out in the East Coast for fellowship, and then I was in the Navy for about 14 years, been up here for about 2.5 years or so now. So looking at the knee, just kind of a basic anatomy stuff here. The ACL is an intra-articular ligament here. You can see it kind of right in the center of the knee and the intercondylar notch attaching over in the tibial spine. It overall has a fairly poor blood supply. Now it has enough of a blood supply when you tear your ACL, you get a large hemarthrosis and effusion afterwards, but overall the blood supply is not great, and that's why things like partial injuries of the ACL tend to not do really well in terms of having a healing response or regaining stability. And there's two bundles of the ACL. There's some literature out there about trying to reconstruct both. Most of the time when we're talking about ACL reconstructions and injuries, both bundles, which are really confluent with each other, are torn, and generally we kind of reconstruct with a single bundle ACL. Function of the ACL, it's really kind of a primary stabilizer to anterior translation. If you think of the anterior drawer test or Lachman test that you do, that's exactly what it's kind of designed to do, is to give you basically anterior translation stability and also some degree of rotational stability. Very important for any kind of cutting or twisting activities or sports that are associated with that. I think it's a picture of Marcus Lattimore, who had a multiligamentous knee over there. When we talk about ACLs, we kind of have this rule of thirds that we used to talk about, and it may be a little bit antiquated at this point, but really kind of a third of patients with an ACL tear will have stability or instability with activities of daily living and sports activities. A third of patients would do well with just regular activities of daily living, but if they tried to return to cutting sports, they'd have problems. And then a third of patients really don't have a lot of issues with an ACL tear, but that's really kind of more for your older athlete and maybe someone outside of the collegiate ranks or competitive athletic ranks. But overall, if I were to tear my ACL, I don't know if I'd need it for ADLs. I probably just wouldn't go back to play men's league basketball or anything. Prevention, this is kind of a big topic these days with ACLs. There's a lot out there about ACL prevention with our young athletes, and especially a lot focused on our young female athletes. I'm sure that you guys probably all have heard of this or do some of this with your local schools and with your athletes. But there's kind of a lot to this in terms of what we do with them, with proprioception training specifically, a lot of cross training, and then conditioning as well, because a lot of these ACL and knee injuries occur as we kind of get later into events when you have some degree of fatigue, and it puts you at higher risk for injury. Overall, the mechanism of injury, there's a lot of these real gruesome ones that are a high impact contact type of injuries, but really most of the ACLs that are torn out there are going to be a non-contact injury. Here's the kind of the famous one from this year with Jimmy Garoppolo just trying to cut or staying in bounds with an ACL tear. Most of your athletes will hear a pop in the knee or describe feeling that sort of pop. You'll get a rapid hemarthrosis. Within about an hour to 2 hours, the knee will be, pretty swollen and painful. And generally, these athletes are not able to continue with sporting activities. A minor MCL strain, sometimes a minor meniscus injury, they'll be able to continue playing. It'll kind of hurt a little, and they'll be able to get through. And when they cool down is when they really notice it. ACL injuries, these are generally kind of, they're being helped off the field and they're not returning to play. It really kind of is self-diagnosed from that standpoint. This is the quick test that we're usually doing on the sidelines when you initially evaluate these athletes. A lot of times if you can kind of catch it right after the injury, before some of the swelling and real pain is set in, you can get an idea. So this is why we're out there kind of checking right away to see if we can really feel there's increased translation. You always have the contralateral side to kind of get a normal for that patient to kind of feel real quick. But here you're just stabilizing the femur with one hand, pulling anteriorly, and you're feeling for that end point. We kind of grade these on a 1 to 3 and whether or not they have a firm endpoint. But really in the end, you're just looking to feel, does this thing translate anteriorly, especially anything more than about 5 to 8 millimeters, and is there a good endpoint at the end? It should kind of snap and feel nice and taut when you do that anterior translation. Looking at other ways for the diagnosis, again, the Lachman, which I showed, they're kind of the most sensitive here. The pivot shift, that's generally something we're doing in the office setting, and usually your knee has to be a little more quiescent, calm down. You're not going to be able to do this in an acute injury, but basically you're kind of putting an axial load on it, you're internally rotating, and then you're flexing, you're kind of feeling that knee. It'll either pop or glide, and we can kind of demonstrate this when we do some of the physical exam stuff later on today, because it's much easier to show than to describe here. We do see a lot of concomitant meniscus tears, and bucket handle tears are the ones that we're most concerned about recognizing early on. And again, that anterior drawer where you have the patient kind of in the supine position, kind of giving them both a posterior translation and then anterior as well, is also helpful. But we find that the Lachman's better where you're actually stabilizing the femur. Most of your young athletes, or really athletes of any age who have an ACL injury, we recommend getting an x-ray fairly soon on these. You know, they're usually patients that should be seen in the ED or maybe at least urgent care within about 24 hours. We want to make sure that we don't see a fracture there. This is what we call a Sagan fracture here. We just see this minor little chip. Doesn't look like much, but that's very pathognomonic for a ACL tear, and is basically the anterior lateral capsule kind of pulling a little fleck of bone off of it. But when we have younger athletes, especially who are not fully skeletally mature, we want to get an x-ray because at times, instead of actually tearing their ACL, they will pull off one of the tibial spines at the attachment there, and that's something that we want to get to surgically fairly quickly, usually within a week or so, and we can actually fix that as opposed to reconstructing the ACL. MRI, most all of your patients with ACL injuries, we're going to be getting an MRI. But really the kind of key here is we should be able to diagnose the ACL injury with examination and history alone. Usually this is A, confirmatory of your diagnosis, and B, we're doing it more to look for other injuries. And those other injuries would be to see if it's a multiligamentous injury like the MCL, PCL, any of the other structures. And you're also looking for bone bruise, any osteochondral lesions, because generally when you have this pretty traumatic subluxation episode, you'll get bone bruise in that lateral compartment. Occasionally, you'll also knock off pieces of cartilage or cartilage with underlying bone. We want to recognize that very early because that will change when we look at treating these patients. And you're also looking for meniscus tears, specifically if you have something like a bucket handle tear, and I'll show you a picture of that in a minute, because if you get a meniscus tear that can be repaired, if we kind of let that wait 6-8 weeks, that may be non-repairable in a young patient, which may affect their outcome, as opposed to if we see that, we're probably going to push to trying to fix their ACL and their meniscus earlier. Just a brief picture here of what a normal ACL looks like on the left. You see that nice structure running from the posterior femur to kind of the anterior tibia there, right over here. And then you can see the other picture. This is what you'll see almost every time. It's pretty, pretty dramatic like that when you see it, that the ACL is kind of ruptured mid-substance. And the other thing about this is obviously not a real acute one because you don't have a huge effusion associated with it. Our goal when we look at reconstructing ACLs, number one is restoring knee stability, both kind of that translation and rotary stability, we'll say. We want to kind of keep the normal motion. One of the big things here is protecting meniscal and chondral surfaces. So, if your athlete goes back, their mid-season tears their ACL and it kind of calms down on them and goes back and has recurrent subluxation episodes or kind of re-injuries, you worry about at that point. If your meniscus and chondral surfaces look fine before, you can definitely kind of re-injure with every single instability episode you have moving forward. A lot of the rehab we do focuses on the quads and hamstrings. You'll see that these patients almost right away will have a bad atrophy within almost a week or so afterwards. Again, surgical results of these things, there is a lot of kind of factors go into it, whether it's patient selection, how you do it, their rehab afterwards, or compliance. So there's a lot that goes into kind of how these patients do in the end. And there's also lots of controversies from a surgical standpoint in terms of what we do with them. Graft selection, whether we're taking a portion of their patella tendon or the hamstrings, and occasionally if we're using things like the allograft or cadaver tissue. Those are all some of the controversies, and there's strong opinions for and against each one of those. How we fix them, this one up here in the top left is what we call like a suspensory fixation, and we'd actually kind of loop a piece of graft over that, and then that little button on the top would be on the outside of the bone, and basically kind of it slides through and then it kind of locks outside the bone and allows that ACL to kind of be suspended, we say, and then the bone will grow into it. Where the bottom picture, I think a little more commonly used for like tibial fixation, is these interference screws where you have this screw that basically goes in and just gives this kind of massive compression around your graft to hold it in place until you get bony ingrowth. In terms of your rehabilitation protocol, I think a lot of our physical therapists work with the sports doctors to really kind of isolate specific protocols for their patients. But you generally will say return to play is around 6 months, and is a lot of times based on their motion and strength and stability in the knee. So it's somewhat individualized. Kind of a common thing that we discuss with a lot of our patients, especially some of our older athletes. Really, there's kind of no need that's too bad that you can't make it worse with surgery, meaning that sometimes we get these multi-ligamentous knees in patients who are really kind of non-athletes at this point. And some of these major reconstructive episodes we have kind of at our disposal, in the end, may not make them a whole lot better. Our young athletes are a little bit different story, though. In terms of overall ACL management, there's kind of just some things or principles out there. Not all ACL deficient knees need surgery. Again, there's some protective effect of having the ACL in terms of decreasing recurrent instability episodes. This is really more for the middle to older age athlete. I would say your younger athletes are almost always going to have an ACL reconstruction. They don't need emergent surgery. You hear about guys in the NFL or other sports tear their ACL and 5 days later they're flown off and they're getting their ACL reconstructed. That isn't really the standard of care for most of our athletes. Our general gestalt is that you want to kind of get the knee to calm down, get some of the swelling down a little bit, get their motion back, and then look at, you will say, a subacute reconstruction. A lot of times the pros are doing this so they can really kind of look at, next season getting the rehab going as soon as possible. And they also have a lot more therapy and time and modalities at their disposal than our average athlete would. Even if you have a multi-ligamentous knee, the most common would be having your anterior cruciate ligament and the medial collateral ligament injured. They don't need to do emergent surgery either. Sometimes we kind of brace them for a period of time, get the MCL to heal completely, and then move forward with reconstruction of the ACL at a later date, 6 to 8 weeks later. There's some thought too that our older athletes, we just put them in a brace and they'd be fine. We find that, conversely, they don't all do well either. That, sometimes our, 40, 50-year-old people, the one that can remain active, they don't always do well with just kind of rehabbing them and getting them back. Sometimes they have a lot of instability that does well with ACL reconstruction. And there is some disability associated with it. Not everybody gets back to their prior level of play. Even with optimal surgical outcomes and a rehabilitation protocol, some patients just never quite get back to where they were. They still have some, some micro instability and some pain that they just don't quite trust the knee. One of the, we'll say, somewhat hot topics here is kind of the skeletally immature athlete. And a lot of these are going to be your patients who are their, 7th, 8th, 9th grade. They're not quite there for skeletal maturity. They're kind of right at their, peak growth velocity. And so our concern with them, with their ACL tears, is that most of the mechanisms we have for fixing the ACL are going to cross the physis or the growth plate. There's kind of conflicting data out there. There's some data that says you can drill a 8 to 10 millimeter hole through that right in the middle and it doesn't affect their growth. But there's also concern and then some other data that just says, well, if you're off a little bit or you're kind of oblique when you go through it, you make a bigger path through that physis, that you can arrest the growth at an area, and then you kind of either have some sort of angular deformity of the knee, or the other worry would be that you actually kind of just cause the growth plate to prematurely close and you end up with a leg length discrepancy. Fairly uncommon, but in the case if they're fairly young and they have a lot of growth left, we also look at doing what's called a physeal sparing ACL reconstruction. And that picture on the side there shows you that basically the blue is the physis, and instead of trying to make in our standard tunnels, which I'll show you in a second, we use tunnels that are that kind of get away from that physis. A little bit harder to reconstruct them using this method, though, a little maybe higher rate of complication. Sometimes if they're fairly stable and they're young, we may just wait a little bit of time, especially if they're not a high level athlete that's in real competitive or something. Wait a little bit of time, let them get towards skeletal maturity, then reconstruct at that time. There's some sport-specific considerations. I'm not going to go through each one of these here, but if you have athletes that are doing a lot of, wrestlers who are going to be on the knee a lot, going to have a lot of direct contact over there, you may consider reconstructing with a hamstring as opposed to a patella tendon, because there's going to be a lot of direct pressure, soreness over that area. Skiing may be a similar thing. A lot of football players, however, because we like a real stiff graft there, and especially a lot of the pro players, they do a bone tendon bone graft, so they use the one in the front because there's there's a little bit higher initial rigid fixation, you can kind of get back to be a little bit more aggressive with physical therapy early on. The one thing I was going to point out here when you get these bad knee injuries, the one that we'd never want to miss would be something like a knee dislocation, right? This is very rare, but I think there's one this year in the college ranks for Central Florida where a kid probably almost lost his leg, and I think he was emergently had to undergo revascularization. So the reason we worry about these knee dislocations is because the popliteal vessels in the back of the knee they have some fairly rigid kind of envelopment with fascia, and so if you really kind of translate that knee significantly, you can tear the artery back there, and then you disrupt blood supply to the basically lower extremity, and sometimes unfortunately can result in things like amputation. So knee dislocation, even if it kind of you're able to pop it back into the sidelines, check vascular status. These are some things that need to go right to the emergency room. We do some advanced studies there in terms of sometimes even arteriograms to ensure that there's no even intimal tears in the artery. Again, these are going to be the one in a career sort of things that you see, but these are the ones too that you never want to miss, and you get them shipped along as quick as you can. In terms of meniscus tears, this is a picture here of what a bucket handle tear looks like. You go in with the scope, and instead of seeing a nice notch there where you can see the ACL or what was left of the ACL, you get this big folded piece of tissue. And that's what a bucket handle meniscus tear looks like when you see it. And you basically have to determine, hey, is this from the medial or lateral side? And then you take something blunt and try to push it in there and reduce it. And I'll show you a picture of what it looks like when it's reduced and then fixed in place. Acutely, a little higher rate of lateral meniscus tears, but chronically, because the medial meniscus is more rigidly fixed there, chronically it's a secondary stabilizer, and therefore if the ACL is out, it takes more stress and the higher rate of tears of the medial meniscus. We do some other radiographic considerations. So if I get a patient who looks like this on your left, has a good-looking knee, they're probably going to be a good candidate for ACL reconstruction. I guess someone who comes in with kind of a loose, sloppy knee, but also has a lot of pain, and they come in with the x-ray there with a lot of arthritis. And this, sometimes we see guys in their, mid-40s at the earliest. We see this sort of thing. They're more a candidate for, sometimes an arthroplasty as opposed to an ACL reconstruction because they have a lot of arthritis. You tighten that knee up, and they're probably not going to be all that happy. And I've actually done a number of cases where we do a combined anterior cruciate ligament and a partial knee replacement in these to get, patients who still want to be reasonably active back to like, things like tennis or racquetball, not high-level cutting sports. In terms of bracing, they're pretty expensive. There's a huge market out there for them, but there's really not a lot of hard science in terms of bracing for prevention. Patient compliance is an issue with these. You get your interior linemen, they don't seem to mind wearing these, but your cutting athletes who are kind of your skill position players, soccer players, most of them will find these somewhat kind of cumbersome to wear. Our goal generally these days is to reconstruct the ACL and rehab it to the point where bracing is non-mandatory, and I think a lot of us now don't even prescribe braces for our ACL post-recovery. In terms of how we do the ACL reconstructions, this picture on the left shows you this is what was called a transtibial technique, where we drill a hole through the tibia, and then we use that same hole to, on that right side, we have this little guide, drill a hole through the femur, and we try to reconstruct this as anatomically correct as possible. There's a couple ways to do it. The one on the left here shows you this is kind of drilling a hole again up into the femur through there. That we also sometimes use what's called an anterior medial portal to try to get that ACL footprint down a little bit farther on the notch. There's some thought that maybe that gives you a little bit more rotational stability. Both of them will give you good translation instability or stability with this, but sometimes a little bit of rotational stability is improved by changing your femoral footprint over there. Again, these are all debatable. There's a lot of people who do them, have great results doing one way or the other for multiple years, so there's not a right or wrong answer in terms of how do you reconstruct them. Again, this is kind of a picture showing, how we kind of fix these. This is with a bone patella bone, where you have a bone block that you're fixing with an interference screw to hold them in place, and that's a very rigid fixation. Usually, that bone block we'll say is about 10 millimeters. We drill a hole that's maybe 11 millimeters, and then we take another screw that's maybe 10 millimeters, so it just compresses the heck out of everything in there, and you're probably more likely to fail at the graft than you are at the fixation early on. So here's just a picture of what these grafts look like. And this right here, there's bone on either end of that graft with patella tendon in the middle. So when you do this, you take about a 10 millimeter width of your patella right in the middle. You kind of slice down on either side, take the middle third of the patella tendon, and then we cut out a portion of the tibial tubercle. So that's what the patella tendon bone graft will actually look like. One of the advantages there is that you have bone that can then ingrow into the femur and tibia when you place it. We also use hamstring, which is taking the medial hamstrings over here, and then also allograft tissue. I kind of just talked about each one of them very briefly. The hamstrings, this is just a picture of how we harvest them. We have these things called a tendon stripper or tendon harvester, and we take the gracilis and the semitendinosus over here, and we just kind of strip the tendon. You will get some reconstitution of kind of some scar-like tendon. You feel someone that's got a hamstring graft, you'll kind of feel over the medial hamstring a year later. You'll feel some reconstitution, but it's not quite the same. They sometimes will have some pain over in that area that persists and a little bit of hamstring weakness afterwards. So there is a downside to it, but you know, the thought is maybe there's a little bit less morbidity than taking the patella tendon. It's overall, the tendons themselves are very strong, but the construct's not quite as stiff because it's hard to really fix them in the tibia and the femur quite as rigidly as you can 2 blocks of bone on either side. And because a lot of times we use what we call suspensory graft, sometimes the tunnels where we drill, and we may drill like a 1 centimeter diameter tunnel in there, over time there could be some motion that ends up kind of dilating that tunnel with the kind of activity. This again is a picture of how we take out that bone tendon bone. Again, it has great kind of ingrowth, early rigid fixation with this. It's a little bit stiffer construct, which may allow you to kind of start rehabbing a little bit early. But again, when you think of anybody taking a chunk of bone out of your kneecap, you have patellar pain afterwards. And there is always that risk of things like patellar fracture, especially kind of early on, because you have compromised the integrity of the patella by taking out a chunk of bone. Allograft or cadaver tissues. This is generally kind of in your 40 and over crowd. It's going to be rare that we use these in young, active patients. A couple of exceptions to be really kind of petite, small patients where we harvest a graft and we get in there and it just is too small. We can't really utilize it for reconstruction, so we can augment with allograft tissue. Also multiligamentous knee reconstruction. So if you're having to reconstruct the ACL, PCL, medial meniscus, medial collateral ligament. When you get that sort of situation, there's only so many places you can kind of steal tendons and tissue from the person's own body, and so utilizing allograft is a good option then. But in your high school kid with a torn ACL, this is probably not a great option for him. The reason being that there's a little slower incorporation, meaning that you're taking basically cadaver tissue trying to get your bone to grow into it. So it just takes a while for that graft to, we could say, fully mature and ingrow. There's a higher re-rupture rate. You can read all kinds of literature about this, that these are the patients that re-rupture their ACL, a year or 2 out. And then, of course, there's things like potential for disease transmission. I think that's really low because they do a really good job of testing these now. But it has a benefit. If I had an ACL at this point in my life, I would probably look at doing an allograft because there's no donor site morbidity, to be back quicker. And outside of goofing off with my kids, I don't play a lot of high-level sports anymore or anything. But again, most studies in your active patient, athlete, allograft is an inferior construct. So you want to use kind of your own tissue. Surgery timing, again, we said, hey, you don't have to do these acutely. You got a little bit of time. You want to kind of get the motion back, delay your reconstruction and to ensure that your knee isn't stiff, because that can lead to more problems. You operate on a stiff knee, it's probably going to be stiff when you're done. So 3 weeks or so is a good time frame. Sometimes we look at kind of the seasonal sports in terms of trying to get them maybe a little bit earlier, or again, if you have something like a displaced meniscus you have to take care of, that's probably an option that you want to get at as quick as possible. The results, overall, 95% plus are very happy though, but 70% of patients really get back to their prior level. And you see this all the time. There's a lot of success stories here out there about patients who return, but for every one of those, there's a few that you don't really hear too much about that never quite got back to where they wanted to be. Kind of the keys here with rehabilitation: early motion, you're early working on your quadricep mechanism, and we usually let these patients weight bear as tolerated, and again, most of us are not bracing them. 6 months or so is kind of an average return to play. I think we kind of covered all of this. I'm trying to keep us going here. Moving on to meniscus injuries. Again, multiple meniscus surgeries of all kind of ages in life. The function of the meniscus, this is a famous, not famous, but a kind of a widely used picture from Arnowski looking at the vascularization of the meniscus. The meniscus over here is kind of that little crescent-shaped structure. And what this is showing here, that's the blood supply. And you can see overall on the kind of to your far left, there seems to be a lot of blood supply. And you look in the meniscus itself, limited to no blood supply. And that's why we have a hard time getting meniscus to heal. It functions as a kind of a load-bearing structure in the knee, a kind of a little bit of a shock absorber, and it also, especially on the medial side, enhances joint stability. So if you cut out someone's medial meniscus, they're going to have more translation there and more kind of a feeling of instability. Isolated meniscus injuries, again, non-contact. This shows kind of the different types of tears looking at the meniscus. Again, the one we worry about, things like the bucket handle tears, that's going to be kind of your young kids. And sometimes these other ones here we see as well concomitant with ACL. The only time this is an urgent issue is if they get a locked meniscus. You know, they're kind of stuck at 15 degrees, it can't extend, or they're stuck in a flex position. These are ones that usually you're going to send on to the emergency department. The way we kind of deal with these a lot of times is we either kind of sedate them or we inject the knee with a bunch of local anesthetic until we kind of calm it down and get them to kind of relax enough that you can kind of at least try to manipulate the knee to get that meniscus to unlock. Very rare that needs to go to surgery right away, but you can't leave them obviously with the knee stuck in 90 degrees of flexion. Our treatment for meniscus tears is really kind of based on a handful of things. Chronic meniscus tears really aren't amenable to fixation. The types of tears too, if you have just like a little flap tear, just kind of a little radial tear, you can't really fix that when it's in that non-vascularized area. The ones that are amenable to fixation are like these tears here where you have them right here because the blood supply is all on the outside of the meniscus. Anything over in here, you try to fix it, you're going to be back 2 months later taking that out. And here's kind of a picture of what it looks like when they're fixed. You can kind of see those little blue things. That's just the suture that we use to fix these. If you're doing just an isolated meniscectomy, you really have no restrictions. You can get back kind of whenever you're feeling comfortable. For sporting activities, sometimes it may be 2 to 4 weeks before you're really kind of feeling good, but it doesn't take that long. You repair a meniscus, different story. Then we kind of lock them in a brace. We can weight bearing extension only. We don't let them do any flexion weight bearing for like 4 to 6 weeks to allow for healing of that meniscus. And it takes quite a while, man, about 4 months or so before you really let them get back. So the difference between doing a meniscectomy and a meniscus repair, not that much harder for the surgeon, a big deal for the rehab and recovery and where they're going to be. That's all I got. Thank you.
Alrighty, so I get the last talk of the day. My name is Steve Rossaretto. Been with Rebound for 10 years also. And we're going to be talking about some return to play considerations. Instead of going through ACL rehab, I thought it would be better for us to go through some return to play decision-making processes, since that's kind of what we have to do as athletic trainers. As the patient or your athlete gets cleared, what are you doing to ensure that they have a safe return to play? What's currently out there? No disclosures, sorry. And so that's why we want to talk about this. It's kind of, I think as trainers, we're put in positions by coaches, parents, other doctors, the pressure for kids. Everybody's got a scholarship type of idea, and it does. I work out at a high school also, and I get those questions put to me quite a bit also. Summary of the talk, we'll talk about some re-injury rates. We'll look through an ACL typical protocol, why the injury rates are important that reflect that time frame of return. We'll look at some current literature, and then I'll just kind of go through piecing together a return to play process that I go through. It's not that it's right or wrong. I think taking through research that's out there, we're going to kind of make a plan of attack to make sure we make the best decision for our young athletes. Starting with just some quick research, just quick bullet points. There's a lot more through these, but just get an idea of, first of all, we know about females having a higher risk. There's also more injury risk in this study with the contralateral knee, the other knee, and other injury rates. If you were under 18, having a higher risk of 17% versus being older. So it starts to build our picture of our group, the group I deal with now in the high school, of why they are at a higher risk. Another study, under the age of 20, females 3 times higher incidence of the contralateral. And that's from a study where they had an average return to play at 7 months. Another one, American Journal of Sports Medicine, the injury rate within 24 months for a female was 5 times greater. So now they're extending out, they're doing more studies beyond 2-year follow-ups, they're going to more 5-year follow-ups and finding out that there's still a higher risk within those first 2 years. Athletes under 25 have a 1 in 4 chance of re-injury if they return back to their sport. This was a male study, not so much females, but again, but 1 in 4 through that, and with early return to play being one of the culprits. So what's out there for return to play? There was a consensus statement in 2016. So they came up with some bullet points here. Return to sport, the RTS, they found that there's lack of evidence. Return to play decisions should be accumulated with a bunch of tests, not just one factor deciding whether or not a person is ready to return to play after ACL. The workload that they're going to be going back to, depending on the sport, and how often they'll be playing, that should be taken into, and then the psychological factors, which we'll be talking about also. Study by Dr. Noyes took 10 years of publications dealing with return to play, return to sport. 40% of those had no criteria based. 32 was time-based only, which we'll see isn't a bad thing. And then 13% took objective criteria, but there was no consensus for any kind of release to sports. Another study in 2017 started putting together test batteries. So in other words, taking more than one factor. They used isokinetic testing, some hop testing, landing. All of them tested at 6.5 months post-op, and all of them failed except for 2 on their criteria for return to sport. In 2016, they took 6 tests, 3 hops, isokinetic, and a running test. The athletes that didn't meet that had a 4 times greater risk of sustaining ACL graft as they followed them out as they returned to play. Rush Orthopedics in Chicago developed a functional sports assessment. So they took those battery tests, they took that information, and they came up with 9 assessments, but their idea wasn't to use it to clear people per se. They did their functional testing at 5 to 6 months and used it to try to identify where that athlete might need more and more work and help guide the therapists and their athletic trainers to concentrate more to help them return to sport. So they're using their return to play or return to sport factors differently. There's some time-based data out there. This is a big result here that they took return to sport play, and the average return was 8 months. I threw that other part in there because anybody who returned before 5 months suffered a re-injury, which we don't really see people returning back before 5 months. Maybe the ones we don't hear about or who don't come to rehab, right? For every month, though, that the return to sport was delayed, they found a 51% decrease in re-injury rate, up to 9 months. So time frame wise, they're starting to find that we know there's biological healing of the ACL graft, and it continues up through that first year. But after up to 9 months, there was a significant amount of chance for re-injury. Hewitt and them, even though it's not per se a study, they just did a review of literature, and they're finding that all their review of literature was done past 5 years on follow-ups, and they're finding that the greatest risk was in those first 2 years, so 15 times higher in the first year, 6 times higher in the second year. So we kind of see we're building up our return to play protocol. We're seeing what group is more at risk, right? We know our young females, we know our young athletes, and those going back to sport in high school or young college athletes. So we're posing the question, what's your return to play process? I'm going to go through kind of what I do. I have 2 different scenarios, well, 3 really. I have a high school process on coaches calling me, so-and-so's had an ACL, I don't know who they are, what am I going to do to help guide them through back safely? I have physicians, Dr. Roberts loves to bring somebody over to me in the clinic and say, this is so-and-so, he's 6, 7, 8 months out, he's back visiting because I did a surgery, he lives somewhere else, can you do some tests with him? So now I got to go through that. And then I have my own patient load that I carry through, and I'm lucky enough to see them through 5, 6 months of rehab, and then what am I doing with them to ensure that they're returning back to sports safely? Are we following clinical decisions? Are we following a algorithm? Are we moving through step? Are we checking boxes? Just get an idea of, you should be formulating some idea of what you want to do to make sure that you know objectively what's going to make your decision on letting somebody return to play from an ACL. So I gather as much information as I can. I call it my little puzzle pieces. I'm gathering as much as I can. Am I building an athletic picture, or do I have parts of it missing? Okay, so that's kind of what I try to do. I use pretty much a systematic system, whether it's checkoff or anything, I try to flow through. So not knowing a patient, if I'm in the high school and someone transfers, we get high school kids transferring because of coaches and things like that. And so Johnny had an ACL 9 months ago. What am I going to do? Well, I'm going to go through these things with them to make sure. So history is going to be really important if I don't know the athlete. If there's someone in my clinic, then I'm going to start on my neuro testing protocol, which we'll go through here. I'm going to test their kinesiophobia, see how they deal with their own pain and fear of movement. Flexibility, range of motion, that's pretty standard. Strength, that's pretty standard. They should be at a certain point if we're seeing them past 6 months. Then we're going to test through neuromuscular control. Performance training and sport-specific drills, that's my favorite part as a trainer. I love that part. That's field rehab. That's getting them out. They've been gone through all their neurological testing, and now we're out on the field. History stuff, we got to know when, where. As Dr. Fraser was saying, the allograft, if we have a young kid under 18 with an allograft, you might as well stop here and just, they're done. I would advise them not to play. Was there any other knee trauma with it? Did they have physical therapy? How long? So we're getting all this information, especially you at the high school, sometimes they'll come from other PT clinics and they'll have their doctor's note and they'll say, hey, we're good to go, we're cleared. How do you know? Got to get some information. Hopefully you can call the physician and get some information about the surgical report. Some of the landmark questions I'll ask people: jogging, typically 3 to 4 months in ACL rehab. Have you done some neuromuscular training program? We start ours at about 5 months. Performance training, agility training, usually we're starting that after our neuro program or our neuromuscular training program, up to 7 months depending. Return to practice, 7 to 9 months. Some are earlier. Dr. Fraser said 6 months for some, and some are phenomenal. Most of the time we're trying to delay, though, if they're under that 20 age. If they're in high school, then we're shooting for a 9-month return to sport. Kinesiophobia, Tampa scale 11, goes through an assessment of fear of re-injury. It's a great little 11-question thing to give to the kids. I'll give it out at 6 months after they've gone through some rehab, after they've gone through their neuromuscular training. It has been shown to help those kids who haven't returned to sport in 1 year, so identify those. So it's a list of 11 questions. The scoring is 11 to 44, so each question is 1 through 4. they would try to answer these questions here. They strongly disagree to strongly agree. These are the actual questions. You can find it online really easy. And as you go through, you can tell that when you get your answer, usually the data's out there. There's a lot of good articles correlating to ACL rehab. And usually the cutoff is around 22 is what I've been seeing as a score, as far as a midline of being more fearful or not. And those are the other questions that would come up with it. So it's good to do. There's some articles out there, like I said, comparing those, some recent, some a little older, but you can find them out there. Flexibility and strength, won't spend a long time on this because they should already be there. The big one for me is one we know with core, proximal stability, FMS screens, other flexibility tests. But the ankle dorsiflexion, that's been a lot lately. Our own Journal of Athletic Training looked at an associated greater dorsiflexion, less risk of ACL injuries. Another study done, females with less ankle dorsiflexion exhibited greater peak knee valgus angle. So it's good to look at. Okay, there's a lot more with the dorsiflexion, so keep that in mind. So we do a little weight-bearing test, lunge tests in the clinic all the time. We're measuring that distance from the toe to the wall on right and left, and seeing where they touch, just looking for symmetrical limb symmetry. And so that's kind of what we start building our picture of the athlete now. So now we might do a Y balance. I want less than 2 centimeter difference. You can use anything. We use a little mat slide. I'm going to look at anterior. I'm going to look at posterior medial. I'm going to look at posterior lateral as they go. Again, comparing right and left and starting to build our picture. Then we're going to get into some neuromuscular control tests. I'm looking for 90% or better to get through this phase. I'm looking at dynamic stability, and I'm going to use my video. It's a 5S. My kids love it because it's really old and they think it's an antique, but it does work really well. We're going to start with some step-down tests. We'll get some scoring done, or you can use single-leg squat tests, whichever you want to call it. Usually we're trying to get them to 60 degrees of knee flexion as they go. Those are errors that we would score them on. And again, we're just looking at quality of motion, quality of movement. Is it good? Is it medium? Are they really poor? Trying to get one test score, piecing it together. This is Emma. She is the #1 rated 7th grade basketball player in Vancouver because she's my niece. So she volunteered. She's not injured, but we see a lot going on for a 7th grader, don't we? This is Lauren, one of our co-workers. So you'll see a difference in strength to a certain point. So it's good to just kind of film a bunch of people if you're working with a team, working with a volleyball team. Usually we'll do this with the whole team and just kind of get more and more you look at, the better. This is Crew. He had an ACL reconstruction, and I'll let you guys decide which leg it is. Yeah.
Yeah, it's gonna clear.
He is only 3 months out, but he was good for video. Yep, and look at yourself, Crew. Yeah, that guy's better. We'll go through some single leg hop tests. So now we're just getting more and more limb symmetry stuff. I need this stuff be 90% and above. Whoops. We'll do the triple hop. Sorry, I skipped the one, not that it's a big deal. Single leg hop. We'll look at crossover hop. This one's a time-dependent one, but I don't really worry about time. I mean, it's going to be pretty obvious with how they do it. if there's an issue, because you're just comparing right and left, again, just looking at functional movement. So they'll go through a one-legged as fast as they can in control. Box drop, we'll just take a look at mechanics. So you can slow it down, you can stop it, you can, do a lot of stuff with it. She shifts over. Oh boy. That's fast. Mm-hmm. Yeah, makes me cringe. Then you can do it, you can slow it down. Ah. Funny, we see a lot more on the takeoff these, don't we? Tuck jump assessment, we'll use the tuck jump looking, sometimes I'll do it at 5 months, at 6 months, and then later if they need it. So I'll use it as an assessment tool also, besides just looking for errors. Those are the errors you're looking for. The first 6 seem to be a little bit more controllable than the last 4. So it's a very difficult jump. If any of you have done your plyos and gone through, we use Cincinnati Sports Medicine as our neuro group. Tuck jump's one of the hardest ones to do. And then from the side, looking at knees parallel, heels coming up, landing in the same spot. Not too bad from the side. Get a little different view. Hair mop. Obviously stronger, but still doesn't quite finish her flexion. Kind of hits stop and gets into that extension right away, which we don't want to see. One of our ACL reconstructions, he is about 6 months out, and he's going to take his sweet time doing this. So we'll start both at the same time. But he actually looks pretty good. So for a big guy, he gets up there pretty good. Yeah. He looks pretty good too, so not too bad. Then we'll take the complete opposite. So Ryan here is awesome. Here's your 14-and-a-half-year-old kid who just thought, oh yeah, it's just like a little bruise. My ACL surgery is nothing. And that's the way his whole rehab has gone. And he is just a jackrabbit. And when we went through his plyos, it's like his technique was good, but it was always at 1,000,000 miles an hour. So I'm not sure about how much strength development we got out of him. He's repeating his neuro program right now. So take off. Yeah, no pause between. He just goes and goes and goes, and he's, yeah, pretty amazing. But looking to get to baseball in the spring, so and this was back in October, so again, just things to look at. This is Ryan, so this is a great case because his knee actually dislocated on me out on the field, and had 3 ligament repair, had drop foot, that's why he's wearing the AFO for now. He's about 1.5 years out, and he's now getting feeling in his toes and his feet. He can dorsiflex, he can evert, it's just waiting on the big toe to come back. And we were filming, and he just wanted to be filmed because he's just like, I'm an athlete, and that's what I want to do. He's actually doing really great. He's starting to run now without his AFO, and he doesn't look too bad. Get up there, Ryan. Get one side view in, and then we'll go. So what if I have someone fail at this point? Well, then we're probably going to, either if it was me, we're going to repeat their neuromuscular control stuff. If I see someone at the high school and they're not 90% limb symmetry, I got to get them through this program. We know these programs work. These are the 4 that are out there right now with the best validated research. Australia has a program, the Santa Monica, the FIFA 11 Plus, anything through those. I'll make sure that we're gonna go back through this, no matter where they're at in the stage. So now at the same time they're doing this, because time dependent, if they're past 6 months, I'll start my field rehab at the same time. So again, reminder, my pieces of the picture. So now we're coming up to performance training, sport specific drills. This is the fun part. This is where we're taking the kids out. We're still doing some plyos. They're on their maintenance plyo program 2 times a week. We're starting to get our agility drills. We're doing ladders, speed drills, cutting, change direction, sport-specific drills, depending on what they are. If they're volleyballers, and we're starting to slide, work on the net, starting to loop around, work on our outside hitting. If they're football, then we're working it out of pads, but a lot of perturbations. So field rehab, this is the fun part, like I said, and so we'll take them through that. At the end, I'll do a certain test. There's a lot out there. I'll show you in a second. I'll use the lower extremity functional test by George Davies. He's got some norms at the top. Lately, this group's been trying to do more and more norms, so it's kind of nice. So anywhere from 100 seconds for the males, anywhere from 117 to 135. Take a 10 feet wide spot by 30, and there's a lot going on, but it's a lot easier to visualize, and you'll see that in a sec. So you go through your routine, and it's nonstop, and you're just yelling at them the instructions. And again, you just get to see them flow. You get to see them move. You just get to watch. So I got Ross, my aide, to participate, ex-basketball player. He's like, I know I can do it under the time, so he's just going to work through. And then while this is going on, it almost went over to come. Also, there's, like I said, there's a lot of other ones out there. There's a good book I got a reference out there for you for other testing that you want to do for agility. They just had the scouting combine. A lot of people use any of that. And if anybody, video-wise, not too bad, huh, Mike? My 5S? Yeah. So again, if he's on the ACL rehab, I'm just looking, limbs, again, right versus left, seeing how much they can do. Little figure 8.
Apparently you didn't give him any breaks.
No, there's no break through the whole thing. Nope, it's straight through. It's, you know, head on the baseball bat, spin around and keep it going, you know. And that's the timing, the norm. So here's a group out of George Fox is doing a lot of pre-testing with it with their Division III athletes. Gosh. Yep, 90 cuts, then you cut on the inside foot versus the outside foot, and then you finish with your straight down and back, and then your backwards down and back. And I promised him I would run it the whole time because he was embarrassed about that.
What was his time?
His time was 2:05. 2 minutes, 5 seconds, so. Other tests, this was, Dr. Riemann is out of Duke, Mansky, I believe, is out of Wichita. They put together a book, Functional Testing in Human Performance. This is their other testing that's out there. There's a lot of them. Some I recognize, some I do not. But obviously you can use different forms of it to test them in that late phase, and all those too. So, return to practice. We talk about medical clearance issues, coaching issues, parent issues. Them coming to you with a clearance note. How do you deal with those? I think education, telling them what to do, or how long it takes for rehab. A lot of them don't understand that. When they get cleared through to get cleared, my biggest conversation with the parents is they're not cleared for games, they're cleared for practice. And we need 4 to 6 weeks of going through practice before we see any kind of game competition. And that's if they made it through my other pieces to the puzzle. So we'll progress pretty simple, 50, 75, 100% non-contact, then go through contact, and then work their way up. The time frame kind of depends, because some kids they're in the club and they only practice twice a week. Some of the high schools, they're out there 5 days a week, so you get a little different advantage. So it kind of depends which scenario they're in. Then we'll go to the return to play. You've got to remember, return to play, we're sending them back to the sport. They're cleared, they're 100%, they should look like they're 100%. They should be ready to go. Some will do some time restrictions, if you have a coach, whatnot, reduce their minutes, how long do they play, and if so, what sports, that kind of variation. The timing of the season's important. Are you getting them in there early? Maybe they don't need to start. Maybe you can delay it longer and longer and longer and longer, because the longer we can delay them, then we know the better result that they're going to have, more than likely. And then, like I said, I have conversation with the parents all the time, with the kids, talking about the timing of, I always want to know when's the earliest they think they can return. I count backwards. I let them know if they have enough time or not. So I always educate the parents on the current timelines, what's needed to get there. Field rehab, need it. That's the biggest gap. Sometimes we don't see our ACL rehabs just based off of insurance, compliance, everything else, and sometimes they're gone by 4 months. And then there they are at the school, ready to go, and they're going to the coaching practices and things like that. So that field rehab part, I feel like, is the most important part. It's also the funnest part, is being an athletic trainer, is getting them out there for that. And then make sure that you guys have an objective process for evaluating. Someone's going to walk in that you don't know, or someone you haven't seen in a while, and now you know why, because of injury. Or transfer patients, transfer athletes, sorry. And you want to have an idea of what you would put them through. Make sure it's objective, so that you okay that one young, my niece who goes to your school, who's going to be a junior, looking that way. I want to make sure how you evaluate them and get them ready. Thanks.